One. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for the third day of Revolutionizing Oncology Pathways to Progress. And we are going to discuss today on lung cancer. And with immense pleasure, I would like to invite Dr. Tarachand Gupta, who is consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you, madam. Ladies and gentlemen, today we are going through the day 3 of this webinar of Revolutionizing Oncology Pathways to Progress. Today we will discuss every aspect of the lung cancer. We gather to share the insights, advancement, and foster collaboration in the pursuit of better outcomes for those affected by lung cancer. Together, let us embark on a journey of knowledge, exchange, and innovation to shape a brighter future in the fight against this formidable disease. So today we are going to touch every aspect of the lung cancer, including the surgery part, radiation part, molecular oncology part, and chemotherapy part. So now I invite Dr. Pulkit Nar, who is a consultant medical oncology in Apex Hospital, for a talk on adjuvant therapy in EGFR mutant non-small cell lung cancer and early stage. Dr. Pulkit Nar, over to you.
Good evening, everyone, and thank you, Dr. Tarachan sir, for giving me the opportunity to share the data on the adjuvant therapy in early stage lung cancer. And I'm very happy to share the data and the syllabus regarding that. Thank you so much. Can I have my PPT?
Yes, sir. Can I run from my side, sir?
Sure. Yeah, so once again, thank you. So I think lung cancer, we all know we mostly get lung cancers in Asian settings, in the metastatic settings. So the survival remains the poor. But nowadays, due to the advanced technology and the advanced imaging, we are able to get the lung cancer in the early stage. So I think our motto is to improve the survival as far as possible by choosing the right adjuvant therapy in the early stage lung cancer. So next slide, please. Yeah, so the survival outcomes in resectable non-small lung cancer needs to be improved. So the lung cancer is the leading cause of cancer death. We all know that leads to around 1.8 million deaths annually, which is a huge number. So NSCLC represent approximately 80% of the lung cancer diagnosis, with an estimated 30% of the patients with resectable disease. So almost like a one third or one fourth of the patients among all the lung cancer do present in the resectable status. Out of which, in stage, if we talk about the global 5-year overall survival rate in patients with resectable NSCLC, so the 5-year survival in stage 1B is around 65 to 75%. In stage 2, it is 50 to 70%. And in stage 3A is 30 to 45%. So our goal is to how do we improve this survival by choosing a right adjuvant therapy depending on the mutation status. Next slide, please. So as we all know that globally, the EGFR mutation prevalence ranges from 10 to 50% in patients with NSCLC, with similar rates observed in early stage and advanced stage. So the risk of disease recurrence following post-operative chemotherapy or other definitive therapy may be increased in patients with EGFR mutation disease versus with EGFR wild type disease. So there is an unmet need to improve 5-year overall survival, which ranges approximately between 45 to 85%, as we have seen in the previous slide, in patients with EGFR mutations ranging from resectable stage, that is from stage 1B to stage 3A non-small cell lung cancer. And as we can see on the diagram of the geographical distribution, that around 10 to 25% is the prevalence of EGFR mutation in Europe, North and South America. It is 30 to 50% in Asia, that includes the Indian setting as well, and 25 to 30% in Australia. So, since being an Asian country, I think it's more important for us to understand the adjuvant therapy benefit in regardance with the EGFR mutation. Next slide, please. So, like, what is the exact timing to do the testing for EGFR mutation? So, now that the current guidelines has said that we can do the biomolecular test from stage 1B to stage 3A, and the two most important tests would they say is one is the EGFR mutation and one is the PDL1 mutation. So I think we both have the therapies available for them. So that is the two most important testing we should done in early stage lung cancer. The EGFR mutation positive, it comes exon 19 deletion and L858R mutation only. If EGFR mutation negative and PDL1 comes positive, or if both comes negative. So we have an approved treatment guidelines as per NCCN and ESMO to choose the correct treatment in either of the three scenario. Next slide, please. So, like, what is the current testing and treatment pattern? So, the prevalence of EGFR mutations in patient with EGF resected stage 1 to 3 non-squamous, that is adenocarcinoma, which is the results from early EGFR study presented in ESCO 2023. So, that they have enrolled patient with surgically resected 1A to 3B adenocarcinoma from March 21 to October 22 and around 33 centers. And what they have found that around 49% of them are EGFR wild type and around 51% of them are EGFR mutated. And among the EGFR mutated, the most common, around 50% is 19 deletion, and around L858R is 36%, and T790M is 3.3%. So we can clearly see that EGFR mutation prevalence was 51% with deletion 19 is the most common, and followed by L858R substitution mutation, which I think we all know is the most common T mutation in EGFR. Next slide, please. So we have three treatment options available for early stage. We all know that is the surgery, we have radiotherapy as well as we have chemotherapy. So overall, if we combine all the three stage from 1 to 3, we have that more than two-thirds of these patients underwent only surgical resection. That is around 73% out of all these patients were able to undergo surgical resection. And with patients with stage 2 and stage 3 NSCLC, only 46% received adjuvant systemic therapy. Now, this is the basically bar distribution of around stage wise, which the blue lines indicates only surgical resection, the gray indicates surgical resection plus systemic therapy, the yellow indicates all three modalities, and the orange indicates the surgical resection plus RT. So we know that the all three modalities receiving is really difficult, and the maximum we have is either only surgical resection or surgical resection plus systemic therapy, which is around 46%. Next slide, please. So, like if we give the initial treatment, more than half of the patient with resectable NSCLC experience recurrence within 5 years. So, if we do surgery upfront, so around 40 to 50% remains cancer free, and around 50 to 60% will still have a chance of recurrence, either locally or distant recurrence. So, given that over half of the patients recur after curative intent surgery, so there is an urgent requirement that we should do something extra to increase that 5-year survival benefit. Next slide, please. So initially, the chemotherapy was the standard of choice after resecting stage 1B and 3A non-small lung cancer, depending on the high risk feature. And the benefit they could have given is only 5% after 5 years. As we can see, if you look at the 60 months cutoff, that is 5 years. So the benefit was 5% both in OS as well as in DFS with a significant p value. So how are we going to improve it? We'll see in the further slides. This is by the Anita study. Next slide, please. So they have various trials has been done and is still going on to compare the various target therapy depending on the EGFR mutation with the chemotherapy. As per the different EGFR status, we have select study for allotinib, radiant for allotinib versus placebo after adjuvant chemotherapy. We have EVAN study that is allotinib versus adjuvant chemo. We have adjuvant CTONG 1104 trial in which we compare gefitinib versus adjuvant chemo. I think some of them have the disease-free survival benefit, but none of these studies basically gets converted into overall survival benefit. And the maximum DFS benefit shown in all these studies is by the adjuvant CTONG trial. So that's what we need a trial which shows a DFS and OS benefit. Next slide, please. So, like, what is the current evidence for EGFR TKI from randomized trials? Basically, this is a meta-analysis of 6 randomized trials, and the BR19, the adjuvant, the EVAN, PC gefitinib, and the Radiant. So, the what they have got it is like there is a 48% reduction in risk of disease recurrence. But as per this meta-analysis, does not convert into the overall survival benefit. Next slide, please. So why have these data not resulted in a change to clinical practice? So trials to date have been limited by design and size of the factors. There is no overall survival benefit. There is an unclear whether if adjuvant EGFR TKI therapy results in cure or it only delay recurrence, or there is no definite evidence on the appropriate sequence, whether to give chemo first then TKI to give TKI first and give chemo on the failure, or to combine both of them? Next slide, please. So I think all these questions maximally would be answered by this wonderful trial by the name of ADAURA. So ADAURA trial basically answers what is the role of adjuvant osimertinib, that is the third generation TKI against the EGFR mutation. So patients with completely resectable stage 1 to 3A who have received or not received irrespective of chemotherapy with the selective key inclusion criteria in which we need EGFR exon 19 deletion or L858R substitution mutation, and the maximum interval between the surgery and the randomization is 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. So stratification was done by stage as well as by EGFR mutation as well as by the race, that is Asian versus non-Asian. And the comparative arms were osimertinib 80 mg once daily, which is randomized to placebo. And the primary endpoint was DFS by the investigator assessment in stage 2 and 3, and key secondary point is DFS in overall population from 1B to 3A. So the planned treatment duration was of 3 years. Treatment was continued until disease recurrence, treatment completion or discontinuation criteria met, and the follow-up was done until recurrence in week 12 and 24, and then 24 weeks to 5 years yearly. Next slide, please. So the trial clearly depicts that there is a significant survival benefit the in stage 2 to 3A, that is the investigator assessment arm, as well as in the overall population. We can clearly see the beautiful separation of the graph between the placebo and the osimertinib. So it clearly shows how benefit that osimertinib has given, that the DFS benefit of 65.8 months versus 21 months, and in the overall population arm, it is 65 months versus 28 months. So there is a clear benefit, DFS benefit with a significant p-value by giving adjuvant osimertinib in EGFR mutation status for early stage lung cancer. Next slide, please. So not only that, it also the osimertinib has significantly improved the CNS disease-free survival. So as we all know that CNS metastases are the poor prognostic factor with NSCLC and are associated with the deterioration in quality of life. So the improved CNS efficacy with osimertinib treatment is because has shown greater penetration of blood-brain barrier and high exposure in brain compared with the other early generations TKIs. Also, adjuvant osimertinib demonstrated CNS DFS benefit versus placebo in both investigation arm as well as in the overall population. So we can see that if the CNS DFS, if compared with the placebo, it is not reached, and there is a beautiful separation of the graph by giving the adjuvant osimertinib in stage 2 to 3A. Next slide, please. So this is basically the characteristic comparison between the osimertinib and the placebo arm. So since if we talk about the race, it is almost equal of 64 to 36. Yeah, and adenocarcinoma the majorly chosen for the randomization. Next slide, please. So if we talk about the overall survival benefit, adjuvant osimertinib, a statistically and clinically significant improvement in OS versus placebo, that is 85 versus 73 months. We can clearly see at the 5 year, the absolute overall survival benefit is 12%. And I think we have previously seen from Anita meta-analysis that for giving adjuvant chemotherapy, the 5 year survival benefit was only 5%. And by adding osimertinib in relevant EGFR mutation, the survival benefit is almost double. So I think it's a great recent trend which has come by the use of osimertinib for the adjuvant therapy in early stage lung cancer. Next slide, please. So yeah, demonstrate in stage 1B, 2, and 3A. If we see the comparison is it is in overall population, the absolute benefit is of 10%. This is also double of almost by comparison to only chemotherapy at the 5 year at the 5 year cutoff. So yeah, the 10% benefit in overall population is also being seen on comparison of osimertinib versus placebo in regarding with the overall survival with a clinically highly significant p-value. Next slide, please. So if we talk about the disease stage, so if we look at the stage 1B, so stage 1B itself has a good overall survival because of the early stage of lung cancer. But the separation of the graph is not so significant. So slowly as we goes from early stage to higher stage, the separation of the graph increases more. So this clearly depicts that the role of adjuvant osimertinib is more as the stage increases. But yes, the benefits do start early from the stage 1B. Next slide, please. So this is the a forest plot showing that the overall survival depending on the various other parameters. And the two most important parameters we want to see is that the EGFR exon 19 deletion, L858R substitution mutation. The maximum benefit is seen in EGFR exon 19 deletion. And if we talk about the chemotherapy, I think the survival benefit seen across both the type of mutations and irrespective of the adjuvant chemotherapy. So either of these mutation or whether adjuvant chemo has been given or not, if it is from stage 1B to 3A with EGFR mutation, 99 L858R, then osimertinib alone can do a wonderful 5-year survival benefit of up to 10%, which is, I think, almost double of the benefit of chemotherapy. Next slide, please. So the subsequent treatment is as the data cutoff for this final overall survival, 76 patients in osimertinib and 184 in placebo arm has received subsequent anti-cancer treatment. So it is, I think, almost half in osimertinib, I think more than half in compared to the placebo. So I think that automatically shows the greater survival benefit osimertinib. And the EGFR TKI is the most common subsequent anti-cancer treatment received across both the arms. Most frequently was osimertinib. Next slide, please. So the no new adverse event was noted when compared to primary readout of ADAURA data. So the grade 3 effect among is around 79 of the patients, and the serious adverse effect is only in one patient. Around 43 leads to discontinuation and 42 leads to dose reduction, and around 91 leads to dose interruption. So yeah, we can wax and wane the dose depending on the side effect. So at the time of current data cutoff for overall survival as per January 2023, the one additional serious adverse effect had been reported, that is COVID-19 pneumonia, which occurred greater than 28 days after treatment discontinuation. The investigator determined that this was not treatment related and the patient made a full recovery. Next slide, please. So the key takeaway points: in order to improve survival, we need to put more efforts to identify lung cancer early. I think that is by the awareness of the lung cancer. Never miss an opportunity to test for actionable mutation. Now this applies in early lung cancer also, especially for EGFR. Also, I think EGFR exon 19 deletion and L858R, if we do it single-handedly, I think there is not even a cost problem in today's scenario. Also, collaboration with the multidisciplinary team is a key to improve the survival. Thank you so much. Thank you very much. But I think in this presentation, some of the left points I think is like how long we should continue the osimertinib, and what exactly should be the sequence, whether we should actually give chemo first or the combination, or in what high risk features or low risk features should be preferred, only osimertinib or chemo followed by osimertinib. Tarachan sir, can you please guide us in that? Hello.
Tarajan sir, your voice is not audible.
Pulkit, what is your question?
Sir, my question is like, how long can we continue osimertinib? Should we give it until progression?
Hello?
Sir, can you hear me?
Yeah, I am there. What is the
Hello. Hello.
question of Pulkit? You are not
Sir,
yeah,
sir,
I
I'm not
can
able to
hear.
hear you.
Hello?
Yes, sir.
Yes. Audible?
Yes, sir. Now audible.
Huh. So I think in adjuvant setting it is for 2 years only.
Okay, sir.
Osimertinib.
Okay, sir.
Okay. Yeah,
Okay, sir.
thank you, Pulkit. It was a
Thank you,
very
sir.
nice
Thank you.
presentation, and it is just elaborative, and it will be helpful for our students if they have joined it. So now for the next talk, I invite Dr. Amit Janu. He is a senior consultant in radiology on Tata Memorial Hospital. He will be speaking upon the staging of the lung cancer. We will touch upon the radiological aspect of staging in lung cancer. Amit Janu, sir, please. Excuse me. Amit Janu sir, please. Am I audible?
Yes, sir, you are audible. Dr. Amit, sir, is your voice is not audible, sir. Yashika, please connect with him. Yes.
He's joining again.
Good evening, sir. Amit sir, good evening.
Yeah, now it is okay.
Yes, sir, perfect.
Okay. Just a minute. I think the slide share is not happening. The slide is shared now.
No, sir.
Now,
No, sir. We are not able to see your slides.
right now.
No, sir.
Oh my God. Sorry, there is some issue. I don't know from what end it is there. Hello.
Sir, can you please share on WhatsApp group?
Can you log out me from one of the this thing?
Yes, sir. Now it is visible.
No. One has to log out actually. Can you?
Sir, you are muted, sir. Amit Janu sir, you are muted.
No, there are two login IDs that has been created. So
Sir,
Okay.
please remove with one ID. There is a sound echo.
there are two logins. Please.
So you have logged in by two system or?
No. I am only one by one system only.
Sir, I have logged out your other ID. You can start
You have
now.
logged out my correct ID.
Sorry.
Anyways, I will reshare. Just a minute.
Sir, your screen is already shared. Just please make it full screen. We can see your screen, right?
You can see the screen.
Yes, sir. Just make it full screen, please. Yeah.
It's okay?
Now you can start.
Okay, thank you so much. Sorry for the technical glitch that has happened. So my talk is on staging, and I cannot. So basically, we work in a we are good that we work in a institution like this where we have a lot of tumor board discussion that are happening each and every day. I'm taking through two cases, one for the early lung cancer and one for the relatively advanced lung cancer. So in this particular case, what we have to go through is that I want to enumerate that this is 73-year-old male patient having a lot of comorbidities. There is having cough, having upper tolerance that is limited. And the patient is having this kind of presentation in which we can see that there are a lot of granulomatous disease. There is a pleural effusion that is there. There is mediastinal thickening that is there. There is a pleural thickening that is there. And what looks to be suspicious is that there is a speculated lesion that actually we can see it. And that makes is that in the background of granulomatous disease, there is going to be an malignancy. And so this is a high risk for that. And similarly, we can see these changes into the medicinal images. So basically, the role of the radiologist is that we have to look for any signs of malignancy. It's whether what is the extent and any other associated findings that might affect its resectability, post-operative course, or issues that are related to chemotherapy or immunotherapy. So one has to see that everything has to be documented and reported, whether it is in relation with the bronchus, that is the viscera, obstructive atelectasis, there is loco invasion into the diaphragm, trachea, and others. And every increase in the T stage, the 5 years or survival will go down significantly. So this is how it will look like. We have to see the size. We have to see whether there is a pleura that is involved, whether the rib that is distracted, whether there is any mediastinal infiltration, satellite nodules, associated collapse components. After looking after this thing, it looks like a 3 centimeter nodule, and to prove it, one should definitely do a biopsy. But there is associated effusion, and it has to be tested whether the effusion is positive because it will upstage the disease. In this case, the biopsy has been done. It was adenocarcinoma that was TTF1 positive. fluid has been tested that is negative for malignant cells. So it looks to be an early cancer, which is negative disease. And the thing is that one need to know that for the metastatic workup, we have to do PET-CT plus MRI brain to rule out the distal metastasis elsewhere in the body as well as MRI brain. But is that enough? We have to also do an invasive mediastinal sampling in these cancer in which we are thinking of a curative intent, and that is with the endobronchial ultrasound. If the endobronchial ultrasound is negative, only then it will undergo a mediastinoscopy. If it is positive, the person will not undergo, or the patient will not undergo the surgery. So this is the case. So PET-CT is in workup of the distal metastatic workup, having a negative predictive value is good, that is around 80%. Still 20% is the caveat. Positive predictive value is very poor. It is variable between 40 to 8%, and it's like tossing a coin. So we can have these regional lymph nodal evolution, like whether it is a contralateral node or ipsilateral node, or it is having a supraclavicle node, that actually we are seeing it. In the mediastinal sampling, actually one can target most of the mediastinal nodes that are in and around the trachea, but not the prevascular nodes that are situated here. So that is going to be the limitation. The need for invasive mediastinal sampling is that our own data at the TMH, it will show that if there is a lung cancer which is having an PET uptake of more than 4 on HPR, it is going to be an 18% granulomatous disease. If we don't do any invasive staging, all these would have been grossly upstaged, received unnecessary chemotherapy, or may have denied surgery, which was the course. But the vice versa also can be true. So in India, we have to confirm, because both the negative and the positive predictive value are not good with any kind of staging system, whether it is a CT or a PET-CT. So this is the sensitivity of EBUS with mediastinoscopy, and these are almost comparable in all aspects. Second question comes whether we need to do an MRI brain in all these patients. Most of the studies will say that in early stages, it is not routinely indicated, but from stage 1 onwards, we have to do in each and every case. But even in the stage 1A, if it is an adenocarcinoma, in our setup, we will advise mediastinal staging to rule out whether there is any other things, and MRI brain also in that condition, because it might have a distant metastatic disease. We can come across various asymptomatic brain metastasis nowadays, because when we do a workup, we will see that the patient are not having symptoms, but we will see all different kinds of metastasis. It may be cystic with edema, non-cystic with edema, solid with edema, small nodules like this, and leptomeningeal disease. All these has been an asymptomatic presentation. So one has to do an MRI brain to work up while the distal ferial has to be ruled out. So because if it is solitary, one can do a surgery, or SBRT can be given. But if it is multiple, then curative intent is not indicated. Either it is going to be WBRT or just a palliative chemotherapy. So just to work up, once we know that there is a detailed clinical history, we have to look for the thoracic and upper abdominal CT to confirm a lung mass, whether there is any complication, having metastasis somewhere else, which can be picked up in the entire region, or whether it is having asynchronous lesions. Once the disease is localized, we go ahead with the PET-CT to rule out the mediastinal nodal disease, or try to find out whether there is any occult distant metastasis elsewhere. If it is localized, then we will go for an invasive mediastinal sampling. And if the EBUS is negative, especially for the contralateral mediastinum, these will undergo mediastinalcopy and subsequently surgery, along with the surgery also. So in this particular case, which is having a lot of other abnormalities, only uptake was seen in the area where it is radiologically looking like a spiculated region, and the biopsy was adenocarcinoma. There were no distant metastasis in this particular patient, but there are a lot of comorbid issues that has been there. Pulmonary hypertension, functions are borderline, and there is other functional limitations. So it is not an ideal candidate for the surgery, and because it might involve a lobectomy versus sublobar resection. But we need to know that in early cancers, there are equally good options as well, like SBRT, CTRT, and radiofrequency ablation. And we have to give the options to the patients and see the merits in which particular setup these can be actually implemented or can be done. This particular patient was planned for RFA, and he tolerated the treatment well, and he was disease-free for almost now 1 year. So this has been discussed with the thoracic surgeon, chest physician, medical oncologist, and radiation oncologist. Coming to the another case that I want to highlight is the locally advanced case. In this patient, it is 35-year, relatively young patient, never smoker, no comorbidities. Again, the complaints are non-specific, dry cough, and there is a weight loss, and on examination, there was no supraclavicular node. What we see here is the 4 centimeter size lesion that is located in the upper lobe, and there is a node that is there in the mediastinum. Again, the biopsy was adenocarcinoma. We can see that this is the mass that is there, but there are multiple nodes. Now here the game will change, that it is a multi-station N2, and here it comes the role of whether we will go for a chemo or we will go for a concurrent chemo radiation or a definitive chemo station. So this is a multi-station N2. In this particular patient, it was planned for definitive chemo radiation, and the treatment was completed in 2020. Again, the issue will arise, how will we do the response assessment and for how long we have to do it, whether it will be CT and it is a PET CT. In this particular case, it was done as a PET CT. We don't advise the PET CT before 3 months because the background activity of related to inflammation is very high and it gives false and spurious results. So after that, if somebody wants to do it, they can do it a PET CT. Otherwise, CT is good enough to know whether the mass has actually shrunk in the size. We are not concerned about the metabolic activity is not shrinking subsequently in the subsequent scans. Then either it may be fibrotic disease or post fibrotic pneumonitis, or either if it is increasing, then it means it is going to be a disease that is coming up early. Once the disease is coming up, then at the time we can evaluate whether it is having also a distal failure as well. So in this, it was looking like a partial response according to the PET. And then these options will arise, whether these kind of patients we have to treat based on the radiology, whether the mass is residual or we have to need to do a biopsy. Biopsy is feasible in these scenarios, and it is relatively very easy setting. And I'm not going into the detail of the options, how we will manage, whether we have to give durvalumab or do observations or repeat after 3 months or do salvage salary. That will depend upon what it comes out to be on the biopsy. So just to conclude the slide, we should be a part of MDT to know the requirements of our medical oncologists, radiation oncologists, and surgeons. And one has to see whether these nodes that are seen on the FDG, whether we have to prove it or not. In each and every case, if it is looking curative from the T perspective and the M perspective, it should undergo a mediastinoscopy and EBUS followed by mediastinoscopy. And negative FDG doesn't rule out the predictability of metastasis elsewhere. And a contrast enhanced MRI is essential to pick up asymptomatic brain metastasis, so we can prevent the futile thoracic surgeries. And we should also know the in early cases, the RFA and the SBRT as a reasonable non-surgical options in node-negative lung cancers. So with this, I would like to end, and I would like to thank Tarachand for giving this great opportunity to interact with you. Thank you so much.
Thank you, sir. And you have guided us very finely in the investigations for the staging of lung cancer. That will be helpful in our day-to-day clinical practice, which sometimes we miss the points. And now we are more wiser after your talk. Now for the next talk, I would like to invite Dr. Virendra Tiwari from Mumbai. He will be speaking about minimal invasive surgery in lung cancer. Dr. Virendra Tiwari, sir, please.
Hi, good evening, everyone. Am I audible?
Yes, sir, your voice is audible.
Yeah, my screen. Can we see PPT?
So yes, can you please make it full screen?
Yeah, I'll try that. Is it now?
Yes, sir. Now your voice is not audible, sir.
Yeah, I'm not speaking only. Just give me a second. Yeah. It's not moving the way I want. 1 second. Yeah, I'll start. Thank you for the opportunity. Am I audible now?
Yes,
Hello?
sir. Yes,
Yeah.
sir.
So today's topic is role of minimally invasive surgery in management of non-small cell lung cancer. I'm Virendra, consultant in thoracic surgery, Tata Hospital. So as we know, lobectomy is the gold standard as far as the surgical resection is concerned for early stage non-small cell lung cancer. Along with that, systematic mediastinal lymph node dissection. This can be done either with an open approach or with a minimally invasive approach. If we see one of a paper published in 2011, which had around 900 patients by Dr. Gail Darling, that is ECOSOC trial, it said that mortality is around 1.5, whereas morbidity is around 38%, that is acceptable with open surgery. Another option that we have minimally invasive. Now there are two pictures on the screen. Right side, it is video assisted thoracoscopic surgery, uniportal, whereas the left side, it is posteral thoracotomy. I think picture itself is little bit self-explanatory. Right side incision is around 3.5 centimeter, whereas the one on the left side, it is 10 to 15 centimeter incision with involvement of significant muscle cutting, rib spreading. Sometimes there is a rib fracture and obviously injury to intercostal nerves. The outcome also, we can judge with the look of the incisions itself. What is VATS? If we see CalGB trial define what is video assisted thoracoscopic surgery. So there are three criteria. Surgery has to be performed under videoscopic guidance. There are 2 to 3 ports with one utility incision of 4 to 8 centimeter, and there is no rib spreading involved. And obviously, if there is no rib spreading, there is very little or nil chances of rib fracture or injury to intercostal nerves. So again, on the right side, I have taken two pictures from one of VATS surgery and another one is from robotic surgery, and both are demonstrating interrobot PA. You can see the magnified view that we get with the minimally invasive surgery. To compensate that, most of the surgeons uses loop or lights during open surgery. So there are some proposed benefit of minimally invasive surgery. It is associated with less pain, faster recovery. There is obviously immediate post-operative benefits like less of a complication, better quality of life as there is a less pain and faster recovery, and earlier they can join their normal lifestyle. Overall reduced cost because of less of a hospital stay, and oncological equivalence is seen with minimally invasive and open surgery as far as resection margin, nodal yield, and the disease-free or overall survival is concerned. Coming to the history of the VATS surgery, it started in 1910, where Jacobius used a cystoscope and a light source to look into thorax, release the adhesions, and take the biopsy. From there, we have moved a long way. In 2022 and 2020 and 22, we have seen uniportal VATS-assisted sleeve resections. Double sleeve, like bronchial as well as pulmonary sleeves, are being performed. So there are multiple case reports to series, and we have 6 to 7 randomized controlled trials also. Technique is advancing. We are advancing. There are less and less number of ports, smaller incision, and more complex resections are being done with the video assisted thoracoscopic surgery. So it's a promising and obviously an evolving technology. Coming to its adoption rate, if we see Society of Thoracic Surgery database from 2001 to 2009, there was almost a 40% jump in the adoption of VATS surgeries, and they had a significant less pulmonary complications. We have meta-analysis which says that morbidity is significantly less with equivalent oncological outcome. As I said, there are 6 to 7 RCTs. There are 3 RCTs which are very recent. I'll highlight those RCT, randomized control trials only. 2016, there was a trial with Bendixson. 2018, one trial by Long et al. Both of these trials were, had a significant number of patients. Bendixson trial has 200 patients, whereas a Long trial had more than 400 patients. Both trials have shown that there is a decreased procedure time. There is a less of a blood loss. Hello? Hello?
Yes, sir.
Yeah, am I audible? Slide
Yes,
is
sir. Your voice is audible.
yeah, thanks. So there is a decreased procedure time, decreased blood loss, less of a analgesia requirement. It is cost effective because of shorter hospital stay. Almost similar complications and oncological outcomes are also equivalent. Sorry. Coming to another recent trial, that is Violet. This was published in 2022. It again randomized more than 400 patients equally into VATS and open surgery arm. They had a pragmatic approach. That is, the hospital protocols were taken into consideration. The analgesia protocols that were followed in individual centers were followed in VATS as well as open surgery arm. Quality assurance was made. The surgeons who were performing VAT surgery had had an experience of more than 40 video assisted thoracoscopic surgery. So there was a good quality assurance as well as a pragmatic approach. What they found that quality of life was better for first 6 months, and after that it was same in both minimally invasive and open arm. There was a less of overall analgesia requirement. Pain score was less on post-operative day 2. Hospital stay was 1 day shorter in minimally invasive arm compared to open surgery. And as far as complications, adverse events are concerned, both were same. Yes, bleeding due to vascular injury was slightly higher in VATS arm, and air leak was slightly higher in video-assisted thoracoscopic arm, but they were not statistically significant. Oncological outcomes were same. There was no significant upstaging to N2 disease in VATS as well as open arm. But another thing that they saw was there was no significant difference in the uptake of adjuvant chemotherapy also in minimally invasive or open surgery arm. Loco-regional recurrence at the follow-up of 1 year were same in both arms. So they concluded by saying that quality of life is better, better pain control, less of a hospital stay, and equivalent serious adverse events as well as oncological outcome. Coming to the global trend, the earlier picture that I had shown that was till 2009. Now this is from 2012 to 2016, and it says that more than 50% of anatomical lung resection nowadays are performed with video-assisted thoracoscopic surgery. Now there is another kid in the block. Till now, I have discussed about video-assisted thoracoscopic surgery. Another thing that is coming up is a robotic surgery. If you see this pictorial representation, it says that uptake of robotic surgery is significantly increasing. VATS surgery is almost constant and open approach is going down. Coming to the cost aspect, video-assisted thoracoscopic surgery is cheaper compared to both open as well as robotic. Problem with robotic is a higher cost. But obviously with the new robots and new companies coming up with robotic instruments, cost is going to go down. There are a few upcoming randomized control trials which are going to compare video-assisted thoracoscopic surgery with robotic surgery, and will get more insight into both minimally invasive approaches. Till now, whatever evidence we have seen, those were for early lung cancers. This is one of the meta-analysis which has seen the outcome of MIS surgery in locally advanced tumor. That is the tumors that are central or involving major vascular structures. Most of the surgeries were either pneumonectomy or sleeve resection, and it says that there is slightly longer surgery time in minimally invasive approach, obviously because they are complex resections, but there is a less blood loss, there is a shorter hospital stay, and there is an equivalent oncological outcome. So not only early stage, even locally advanced disease can be managed with the minimally invasive approach. But at the end, I would like to conclude by saying that most important thing is a maximum safety of a patient and a best survival outcome. Approach is a secondary thing. If a surgeon is comfortable with open approach and he can save lung by sleeve resection doing in open approach, then it is better to go ahead with that approach rather than pushing for minimally invasive surgery. Minimally invasive surgeries have shown a better short-term outcome, but oncological equivalence is the same in both approach. Thank you.
Thank you, sir. And sir, the question is where you recommend for the mediastinoscopy for staging. If the patient is PAT positive, then you recommend or not? And even patient is having a PAT positive disease on ventricle.
Yeah, I think in previous talk, Amit sir has already mentioned. So invasive mediastinal staging is needed in almost all cases. There are only two scenarios where you can avoid invasive mediastinal staging. One is a peripheral T1N0 on PET. Another
Okay.
catch is adenocarcinoma histology with high FDG avidity. Those tumor, even if they are peripheral, you should push for invasive mediastinal staging. Second thing, if there is a frank, conglomerate nodal mass or a primary tumor going into mediastinum and forming a, infiltrating all the way till nodes, then in those cases, they are conclusively positive nodes. In there, you can avoid. Whereas in rest of cases, if you are planning for a surgical management, it is better to go ahead with invasive mediastinal staging. There are two forms of invasive mediastinal staging, that is EBUS and mediastinoscopy. EBUS is less invasive compared to mediastinoscopy. Preferred thing is to go ahead with EBUS. If EBUS is N0, confirm that finding with your mediastinoscopy. If EBUS has given you N2 or N3, then accordingly proceed.
Thank you, sir. Thank you for a nice talk. Now I invite for the next talk, lung cancer in World Conference on Lung Cancer in 2023, Dr. Vikas Talreja, Rajnikant of Kanpur. So, Dr. Vikas, over to you.
Thank you, Dr. Tarachan sir, for that tag, and definitely an intellectually awakening agenda. I must congratulate for a beautiful congress so far. And lung cancer has seen so paradigm shift that I believe it can't be summarized in 5 or 7 minutes. But yes, something which has changed the way we treat lung cancer, especially the advanced EGFR mutation positive non-small cell lung cancer, was 5 years back when Flora was presented. And now the Flora 2 has been presented in the World Lung Cancer Congress in September 2023 in Singapore, where Professor Jain presented this keynote presidential session on osimertinib with and without platinum-based chemotherapies as the first-line treatment in patients with EGFR mutation-positive advanced non-small cell lung cancers. So I hope my slides are visible right now. And these were the slides which were being used by the same professor. So EGFR TKIs, as we know, has been the standard of care for advanced non-small cell lung cancers. And despite many of them, they were always associated with poor prognosis, including the CNS MET and the L858R mutations, which haven't shown so much benefit with it. And that's where the osimertinib had a beautiful data on Flora 5 years back with a PFS and OS benefit. Now, osimertinib plus chemotherapy had some phase 2 OPAL study done in Japanese population, which showed that there was a response rate of around 91% and a median PFS of around 31 months. So, however, this combination had to be evaluated in a randomized trial because it was a definitely a phase 2 data, and that's where this concept of combination of chemotherapy and the osimertinib do play a very important role. So the Flora 2 was designed and the patients were stratified whether they was Asian or non-Asians, metastatic non-small cell lung cancers with a preserved performance status, and stable CNS metastasis was allowed in the population. Brain scans were present at the baseline. Chemotherapy was pemetrexed carboplatin with AUC 5 or cisplatin 75 milligram per meter square, depending upon the physician choice, with 4 cycles of the same, followed by maintenance pemetrexed, and the other arm was the osimertinib 800 milligram. So chemo plus osimertinib versus osimertinib alone, and the patients were followed up with the primary endpoint of PFS, secondary endpoints of OS, overall response rates, duration of response, disease control rate, health quality related life, and the PFS too. Now, if you look at the patients, around 500 patients of them were randomized and 276 were randomized into the either of these arms. And if you look at the chemotherapies, around 23% discontinued carboplatins and 75% of these patients discontinued pemetrexed. And half of these also discontinued osimertinib in either of these arms. Disease progression, adverse events were the most common reasons of the treatment discontinuations. So baseline characteristics, the CNS metastasis, the EGFR mutations, adenocarcinomas, the smoking status were exactly matched between these two patients subgroups. And if you look at the progression-free survival as per the investigator, as you could see, the addition of the chemotherapy did have a meaningful PFS benefit with what 38% reduced chances of progression with an hazard ratio of 0.62 from 16.7 months to 25.5 months, even though Japanese data was 30 plus months, but yes, 25 months of the combination of osimertinib plus chemotherapy. So if we look at the data, 2 years of giving the first line therapy for an advanced non-small cell lung cancer. So stage 4 lung cancer without progression for 2 years means a lot for most of our patients. And yes, the median PFS, as you could see, improved by a magnitude of 9 months. Now, from 41% to 57% at 2 year benchmark, and from 66% to 80% at 12 months benchmark shows a remarkable benefit out of these patients. If we assess by the independent review committee, again, when that's the figure, you see approaching towards the Japanese ballpark figure of 30 months. So osimertinib plus uh, platinum amitrexate combinations, median PFS 30 months as compared to osimertinib 19.9 months with a 40% reduced chances of progression. I believe we can safely say that 1.5 or 2.5 years, the patient is not going to have a progression. That means a lot, especially for a first line metastatic advanced non-small cell lung cancers for the same. Now, if you look at the which subgroups did have a benefit, and that's where the graphs were different from the flora. So when we were discussing the flora trial, L858R was the population where we thought that the curve was exactly in the midline with a hazard ratio of crossing unity. Here you see 40% of the patients didn't have a progression when they were given osimertinib plus chemo. So whatever the negative effects or probably the negative prognostic factors was there in flora was neutralized by addition of the chemotherapies, and therefore the PFS benefit was consistent across all predetermined subgroups, irrespective of it was age, EGFR mutation type, CNS, brain metastasis. Even those patients who had a brain metastasis had a 50% reduced chances of progression, local and intracranial, when the chemo and the TKI combination was given. So definitely a practice changing for most of us. So PFS, again, if you look at the brain metastasis patients with or without, especially with CNS metastasis, 50% of them didn't have a CNS metastasis. So that was a highly anticipated group where the flora had a limitation. So L858R and the CNS metastasis were the groups where we were thinking that yes, the negative prognostic factors where the osimertinib couldn't improve were seen with the addition of the chemotherapies, where you can see with the addition of the chemotherapies, the hazard ratio was 0.63, meaning a 37% reduced chances of progression. Now, very important is the time of the overall survival and the PFS2. And you could look at the overall survival for now. The events haven't occurred, so it is difficult to comment right now. But PFS2, you could see the late separation of those curves. So definitely, I believe that's also going to be a very important discussion in the subsequent as the final data mature, probably in the next year lung cancer congress at Singapore again, possibly would be the thing to look forward to as the updated analysis of the PFS2 and the overall survival do come. And if you look at the objective response rate, you could see with the addition of the chemotherapies, the, the, the swimmers plot were quite deeper, and the duration of response was higher, longer. 15 months to 24 months, that's 2 years. If the response is there, that's maintained over the next 2 years. Now, there were a lot of partial responses and a lot of disease control rate. And if you look at the response rates, that's where probably is something we need to add the chemotherapies. Now, as we see, the duration of exposure was around 22 months for in the osimertinib plus the chemo arm for the osimertinib, and the treatment related discontinuations was fairly manageable as with any standard therapies. And with the addition of chemotherapies, you expect the graphs to grow more red, and that was there. There were more anemias, diarrheas, nauseas, laboratory derangements with the addition of the chemotherapies. But yes, these are all the part and parcel of when you're expecting a better response in a negative prognostic subgroup. And ILDs were also reported in those patients which were with osimertinib and the chemos form. So definitely osimertinib with chemotherapy is a game changer for now, with a statistically and significantly clinically meaningful benefit in the PFS over the osimertinib in patients with EGFR mutation, advanced non-small cell lung cancers, with a magnitude of around 40% with the current standard of care, that's osimertinib alone. And if you look at the improvement of the investigator assessed PFS, that's 8 months. If we look at the independent review committee uh, improvement, that's 10 months. Then the PFS we are talking in terms of 26 to 30 months. That's again the first line advanced non-small cell lung cancers, including those patients with a brain metastasis. That's something which is really look forward to. Ongoing analysis does include a CNS response rates, patient-reported outcomes, post-progression endpoints, and the circulating tumor DNA analysis. And that's where I believe the data is going to be very encouraging for us. So thank you for your patient listening. I hand over to the organizers and would love to answer any questions if there are any.
So thank you, Vikas. So now you are changing your practice on the basis of Flora 2, or you don't think that this is mimicking our training time, that GC versus JF versus GC, you remember?
Absolutely, yes, sir. I believe
and
that's
that
where
has come
this.
now. That has come now,
Yes.
no?
Absolutely, yes. I believe this is going to be a practice changing in future times, because many of the times when we tend to think of osimertinib, we've thought that yes, the Asian subgroup was those who didn't have a benefit. L858R was the group which wasn't having a benefit, and the CNS metastasis was the group which hadn't had a benefit. So again, osimertinib had its limitations, and that's where I believe this data gives us a Monday morning practice changing thing, that yes, it's not only the osimertinib, you need something more than osimertinib to get a better advantage, longer advantage, and a durable advantage. And we are talking in terms of 2 to 3 years of first line treatment of lung cancer of EGFR mutation positive. That's something revolutionary right now. And if we look at 4 year 5 year data for this, if I believe if we extrapolate those curves of the overall survival, 50% of those patients are crossing the benchmark of 5 years. So again, that also is making a different change in the EGFR positive lung cancer.
This study has proved कि है ना, मूंगफली गरीब आदमी का बादाम है ना, जेफेटिनिब plus chemo is equal to osimertinib.
Absolutely, sir.
Thank you, Vikas.
Thank you.
Now we are moving towards the next talk, and I invite Dr. Anil Tivedwal from Mumbai for he will enlighten us with a talk on radiation in early lung cancer with the recent advances. Dr. Anil Tivedwal.
Sure. Thank you, Dr. Tarajan. Yeah, let me share my screen with all of you. So at the outset, I would like to thank the organizer, Dr. Tarajan, for giving me this opportunity. I hope my slides are visible and I am also equally audible. So I am about to speak on radiation in early lung cancer, recent advances. So as far as the radiation is concerned, the role of radiation in early lung cancer is specifically limited to T1 to T2 N0 M0 if we classify early stage lung cancer by N0 status. So the major role is of the SBRT. So we should define SBRT for the benefit of the audience. It is a method of external beam radiation therapy that accurately and precisely delivers higher doses of radiation in one or few treatment fashion to an extracranial target. So that is the lung, so thoracic. So SBRT is So delivering a very high doses of radiation as compared to conventional radiation therapy in one or few fraction. It is highly precise, highly conformal, very high dose per fraction. Only 1 to 5 fractions are required. It has got a very steep dose gradient so that the normal tissue is not going to get very high doses of radiation therapy, and is very minimally toxic. It is an outpatient procedure, non-invasive. So this is important. This is a non-invasive procedure. It gets over in a week or two. It has got an excellent local control and a comparable overall survival as far as surgery is concerned. Stage-wise management, we are not going to go into details about that, but T1 to T2 N0, the role of SBRT is there, in especially in medically inoperable. The role in medically operable is still evolving, but if the patient refuses the surgery, then yes, so SBRT can be offered even in medically operable patient also. How do we select our SBRT patient? So based on the tumor size, so generally less than 5 centimeter in size, node status should be N0. The location can be different, peripheral, central, ultracentral, but we need to be very cautious in terms of the ultracentral location. The patient should have an adequate pulmonary reserve, and the patient is medically inoperable or operable, that we need to see. What are the challenges of lung SBRT, especially in thoracic cavity? The lung itself is moving, so the tumor is also moving, and we get to see the tumor of less than or equal to 5 centimeter in size. The smaller tumor size makes it very difficult. The lung tissue interface is a challenging aspect as far as the radiation physics is concerned. The moving target, moving organ at risk, the tumor as well as the lung, both are moving at the same time, as well as our machine. The moving MLC, that is the multi-leaf collimator, is also moving. So we need to identify a coherence so between the moving target, the organ at risk, and the MLC, and then we will be able to deliver the SBRT, especially in the lung cancer. So delineation and dose, the GTV is the same as you can see on the imaging. Clinical target volume is equal to GTV. There is no margin for microscopic disease. ITV is the account for tumor motion. That's the motion that you are encountering while delivering the treatment. And planning target volume is 5 millimeter from the GTV. So these are the different doses that has been given in various RTOG and in the TMH and in the JCOG trial. So there are various prospective studies which have shown that the 3-year overall survival is approximately 45 to 55%. So this is the first RTOG0236 prospective study which have shown that the 5-year overall survival is close to 40%. These were all the medically inoperable patients. So this study from Japan has shown that you need to deliver an equivalent dose of 100 biological equivalent dose to achieve a better local control and an overall survival. The SBRT dosage should be at least 100 gray BED and not less than that, because if you deliver lesser dose, then your local control as well as overall survival will be less. The 5-year overall survival in this particular study was approximately 65% for medically operable patients. So this is the JCOG 0403. These are the long-term results. So mind you, there is a 10-year overall survival result. So that has been published. So the 10-year overall survival was 24% and 10-year local control was 85%. 85% of local control in stage 1 non-small cell lung cancer was unheard of. So with the SBRT, but the Japanese guys has shown that with SBRT you can have a local control of 85% at the rate of 10 years. So these were the randomized control trial which were happening so between the surgery and SBRT, but unfortunately all were terminated due to the poor accrual. The reason we all are slightly aware of, the failure of the thoracic surgeon to participate, and they declined to join the study irrespective of whether they were able to do the VATS or not. So this was the pooled analysis of the two randomized control trials, STARS and ROSEL, and the patient population was less, approximately 55 patients only, but they have shown that the 3-year overall survival was 95% in SABR versus 79% in surgery. The criticism of this particular pooled analysis was that so whatever the surgery has been done was not the VATS, but were of the open category, open thoracotomy. So the author have decided to continue enrolling the patient in a single arm trial, and they have named it as a revised STARS trial. Long-term result of a single arm study. 5-year PFS and OS you can see is 77% and 87%. 5-year overall survival of 87%. All of these patients have been uh, termed as the medically operable, and they were compared with a published institutional surgical cohort. And which is the institution? It is the MD Anderson Cancer Center. On the propensity score matching, they have found that the 5-year overall survival was 87% with SBRT and 72% with the surgery. The VATS has been done in all of those patients at MD Anderson Cancer Center. So in this particular paper, it's a non-randomized one, but it's of the MD Anderson Cancer Center, and all were the medically operable patients. So this is the paper which have shown that whenever you treat a lung lesion close to the hilum, you need to be cautious. You need to reduce your dose per fraction, otherwise we can cause a major toxicity. So the dose per fraction should be decreased from 20 gray per fraction to 12 gray or 10 gray per fraction. So the central tumors, so this is the area that you can see in the shaded line. So this is the central area, and the RTOG 0813 has also shown that the PTV touching the mediastinal or pericardial pleura is also termed as the central tumor. So this is the outcome of risk adapted fractionation depending on the location. If you give the 20 grain 3 fraction in a centrally located tumor, you will have maximum toxicity, and then you will not be able to save the patient. And if you reduce the dose per fractionation, your local control will be the same and the overall survival will be improved. So these are the ultracentral tumors. These are slightly notorious for the surgery also, as well as for the SBRT also, because they are very close or very adjacent to the central structure. You need to reduce your dose per fractionation to approximately 5 to 7.5 gray. Otherwise, you can have a 10 treatment-related death in this particular patient population out of 65. So approximately 20% treatment-related death if you do not control your dose per fractionation. So why not conventional EBRT? We have been shown by 2 randomized control trial that when you compare SBRT versus conventional EBRT, your esophagitis rate are increased. However, in this particular paper, overall survival was same. But in the Chisel trial, the next trial, the overall survival at 2 years was much better in SBRT arm as compared to the conventional RT arm. So SBRT is preferred over conventional EBRT in stage 1 non-small cell lung cancer. So these are the ongoing studies. The saber tooth has just been concluded and has been published also, and they have shown that they were unable to accrue the patient 3 to 4 patients per month in this UK-based randomized control trial. But they also mentioned that it is not feasible, but a significant proportion of patients randomized to the surgical group, they declined the surgery and chose SBRT as a treatment modality. So if given an equal treatment option between surgery and SBRT, the patient might choose SBRT over surgery based on the early results of those particular phase 2 studies. What is the role of chemotherapy? The role of chemotherapy is not well defined. This is the database from the NCDB analysis, and they have shown that whenever you give a chemotherapy, adjuvant chemotherapy based on the tumor size of more than 4 centimeter, you can have a lesser distant metastasis as well as the regional nodal metastasis as compared to no chemotherapy. So chemotherapy might benefit, but we do not have any level 1 evidence to prove that. Now, what is the role of the immunotherapy and as a part of multimodality in stage 1 non-small cell lung cancer? So this is the phase 2 randomized control trial where they have given neoadjuvant durvalumab with or without SBRT in patients with early stage non-small cell lung cancer, and they have shown that the major pathological response after surgery was much better when you combine SBRT plus the immunotherapy. So immunotherapy might get enhanced by the SBRT. So a phase 3 randomized control trial is ongoing, and we should wait for the result of this particular arrangement of neoadjuvant therapy. So what is the role of SBRT before surgery? So this was the missile trial, and they have shown that when you do SBRT before surgery, so this was done in the era of COVID, to have the gap between the surgery and SBRT. So they deliver SBRT prior to the surgery, and they have shown that the pathological complete response rate was approximately 60% when you deliver SBRT before the surgical cohort. So what is the role of SBRT in oligometastasis? I'm slightly divergent from early stage lung cancer, but in the case of the synchronous oligometastasis, when you have T1, T2, N0, M1A or M1B disease, B is the oligorecurrent. So because there are many patients who are being seen as an oligorecurrent or oligoprogression, especially in the EGFR era, and D is the oligopersistence. So this is the oligometastasis in this. So in this particular paper, we all know that SBRT as a form of local consolidation therapy has helped in improving the PFS as well as the overall survival. So this is the pembrolizumab after completion of local ablative therapy for oligometastatic non-small cell lung cancer. This was also a phase 2 trial. It has also shown, as compared to the historical cohort, the 2-year overall survival was 78% when you combine the local consolidation therapy in the form of SBRT to the primary as well as the metastatic side. So this is the paper that we just submitted for the oligoprogression. We treated approximately 70 patients, and we have shown that the median overall survival can reach up to 50.6 months when you have the category of the oligoprogression and you deliver SBRT for the oligoprogression patient. So in summary, I can summarize that SBRT has an excellent local regional control rate. It has got a comparable 5-year overall survival, but the randomized data is to be awaited. I don't know when it is to be available. The SBRT has got a minimal toxicity. The risk adapted approach for central or ultra-central tumor is being warranted. Otherwise, you can land up in the toxicity. The newer indications are for the lung oligometastasis and neoadjuvant approach. So with this, I would like to conclude my talk and would be happy to answer any questions.
Dr. Anil, in the era of immunotherapy and EGFR, whenever we are treating oligoprogression with the radiation, how are you comfortable when we know that these drugs can cause the pneumonitis also? So how do you manage, or what is your experience in the managing the oligoprogression of the with the SBRT in the patients on anti-EGFR or immunotherapy drugs?
It's an excellent question because for majority of the time, the literature has shown that EGFR TKI cannot be combined with the radiation therapy because of the risk of the lung toxicity and everything. But if you see the recent paper, and so with our personal experience, all of our oligoprogression patients are ongoing on the geftinib or afatinib, and we are continuing with the SBRT, and we haven't seen any major or grade 3 or grade 4 the acute radiation or the EGFR TKI induced pneumonitis. So I think as far as the first generation or the second generation is concerned, it is pretty safe. So because we have not treated a too many patients of the osimertinib and the SBRT, because for the osimertinib to have the median progression is approximately 18 to 20 months, and we are not treating patients with the osimertinib in too many numbers. But the first generation and the second generation, it is pretty safe.
Okay, thank you, Dr. Anil, for a nice talk. And good evening, Somani sir, for joining us. And now I invite Dr. Kunal Jovan Patram from Mumbai. He will be talking about neoadjuvant and adjuvant immunotherapy in early lung cancer after the talk of radiation.
Thank you. Is my screen visible?
Yes, screen is visible.
Yeah. So good evening, everyone. Today, my topic of discussion will be neoadjuvant and adjuvant immunotherapy approaches in early stage lung cancer. So as we know, the survival outcomes and the prevalence of resectable non-small cell lung cancer, they need to be improved because as we go from stage 1B to 2 and then stage 3 in patients who are patients having resectable NSCLC, the survival goes up to 30 to 45%, 5-year OS rates in resectable non-small cell lung cancer, and this is an unmet need to decrease the recurrence and improve the survival in this group of patients. So between 30 to 70% of patients, as I mentioned, experience recurrence following complete surgical resection. And if we look at various stages of lung cancer, if in stage 1 and stage 2, around 20 to 30% of patients recur. And in stage 3A, as we can see in the diagram, that the recurrence patterns are usually common in the earlier years, that up to 12, its recurrence is more common in the first 1 or 2 years. as we can see from the bar diagram. And compared to the stage 1 and 2, there is substantially higher risk of recurrence in stage 3A group of patients with an resectable non-small cell lung cancer. So stage 3 is a heterogeneous a group of disease, and we can see that very few patients of stage 3, like for example, 1/5 of patients of stage 3 are resectable. They ultimately undergo surgery, and very few patients of stage 3B undergo surgery. So why we are discussing? Because the inclusion criteria of various trials includes a few of these patients of stage 3 cancers also. So evaluation of neoadjuvant immunotherapy started with use of neoadjuvant immunotherapy alone, with a initially phase 2 designs with single agent immunotherapy, and they found that it was associated with improved pathological complete response and major pathological response. They also then studied dual immunotherapy combination. They found better responses, better PCR rates, but again with a caveat of higher toxicity, like always. So a single agent immunotherapy with chemo was started. Also, there was there is a hypothesis that chemotherapy increases the antigen presentation, hence making immunotherapy more efficacious, and immunotherapy again restores the immune environment. So with the logic of improving the antigen presentation, improving the immunotherapy responses, and also to avoid more patients going into progression before surgery, the combination of immunotherapy with chemotherapy was preferred. So there are various trials. First, I will discuss the neoadjuvant settings. Though it started with a few trials like the LCMC trial, which used atezolizumab single agent immunotherapy in the neoadjuvant setting with a PCR rate of 6%. Then the NeoStar trial used the combination. NeoStar and the subsequently the trial by Rios et al. Used the combination with a PCR rate going up to even 30%. Then the NeoCost trial used durvalumab along with various newer agents, and the PCR rate was around 9 to 10%. But the main trials in neoadjuvant setting, for which we have a good number of patients, and also some follow-up, is Checkmate 816 trial. So I will discuss the Checkmate 816 and also the Nadim 2 trial. Nadim 2 trial also used nivolumab along with chemotherapy, and the PCR rate again here was very impressive, going up to 36%. So this is the summary slide of various trials in the neoadjuvant, adjuvant, and now we are also seeing many trials in the perioperative setting. So in the neoadjuvant trials, the Checkmate 816, we have an approval of nivolumab in the use of early lung cancer in the neoadjuvant setting, and where it is given for 3 cycles followed by surgery. In the adjuvant setting, we have 2 trials, the IM Power 10 and the Keynote 91, which used atezolizumab and the pembrolizumab respectively. In the perioperative setting, we have Keynote 671. The Asian data and other trials are coming up with outcomes are awaited still. So what are the theoretical advantages of neoadjuvant? As I discussed, higher antigen load released from the dying cells in the untreated tumors, better priming of the immune system. The immune system is fit that time. No significant clonal evaluation. Tumor could be less heterogeneous that time. Opportunity to accurately study the effects of ICB. We have a pre-operative and a post-operative sample. We can assess the biology of the tumor, ability to assess the efficacy of the therapy, and also we could have a shorter time frame to completion of trials, and we can have earlier surrogate endpoints to predict the survival. So also we need to discuss about the trial endpoints. So major of these trials had at endpoints of major pathological response, that is less than 10% of viable tumor, and pathological complete response. These trial endpoints were taken as a surrogate to predict the survival outcomes earlier, because in various studies it has been found that there is some correlation between the MPR and PCR rates with the DFS rates. So this meta-analysis of ICI and the chemo immunotherapy combination trials, they have pulled the data and found out that they tend to correlate with the DFS outcomes. So one by one trial we will discuss. So this is a neoadjuvant trial of Checkmate 816. It included newly diagnosed patients resectable, any tumor about 4 centimeter up to stage 3A non-small cell lung cancer as per the 7th edition of TNM, with good ECOG performance status, and EGFR and ALK mutations were excluded, and randomized in 1:1 fashion, giving nivolumab for 3 cycles, 3 weekly dosing, 360 milligram, and then after radiological staging, surgery was done within 6 weeks of post-treatment. So here the primary endpoint was pathological complete response by a blinded independent review and EFS. The secondary endpoints included overall survival. So this is the brief schema of that 98% of the patients received neoadjuvant treatment in the Nevo chemo arm, and similar figure in the chemo arm alone, and 94% of patients completed neoadjuvant Nevo plus chemo in the experimental arm, and 16% surgeries were cancelled because of disease progression in 7%, adverse event in 1%. So even if you see the surgery duration also has been, we can see there is a reduction in surgery duration of 180 minutes compared to 217 minutes in the chemotherapy arm. If we see the pathological complete response by stage wise, then the PCR rate went up to 40% in stage 1B and up to 23% in the stage 3A. So it was observed, the PCR improvement was observed with the experimental arm of chemo plus immuno, regardless of the radiological downstaging. Now the survival outcomes. So survival outcomes, if we see the 3-year EFS rate, it was 57% versus 43%. And the median follow-up was around 40 months. And median EFS, again, we can see that it was improved from 31 months versus 21 months in the Neo plus chemo arm with a hazard ratio of 0.68. Now we look upon the Asian trial. This again was a phase 3 trial, double-blind study with a treatment-naive population with a good ECOG performance status. And here they included patients of stage 2A to stage 3B N2 disease according to the 8th edition of AJCC. And they included the patients having PDL1 confirmed status with no documented EGFR and ALK aberrations, but initially they included, but then after the trial protocol amendment, they excluded the EGFR ALK aberrations having those mutations, and again randomizing to 1:1 fashion, receiving durvalumab plus chemotherapy versus chemotherapy alone, and durvalumab he was given for 4 cycles pre-operatively, and then after surgery they were again continued for 12 cycles. Here the endpoint was PCR rate and EFS rate. And again, here we see an absolute improvement of PCR rate of 13% in the overall population, ITT population, and an improvement of 21% of major pathological response in the intention to treat population. So PCR rates improved across all the subgroups. And if we look into translation into EFS improvement, again, the hazard ratio was 0.68, 32% reduction in the recurrences. And the median EFS was not reached in the durvalumab arm compared to 25% in the placebo arm. And 2-year EFS was 63% versus 52%, around 10 to 11% improvement in the EFS. Here EFS by subgroups. So the PDL1, the PDL1 expression by TC 1 to 49%, and more than 50% had better outcomes in terms of EFS. So the third trial here is the Keynote 671. Again, it used pembrolizumab in the perioperative setting. Similar inclusion criteria. Stage 2, stage 3A, stage 3B included N2 as per AJCC 8th edition, and with a good ECOG performance status, and the patients were stratified according to the TPS scores, less than 50 and more than 50. And here the pembrolizumab was used for 4 cycles preoperatively, followed by 13 cycles, completing 1 year of perioperative pembrolizumab. Here the important part is the endpoint. The endpoint here was EFS along with OS. So that is a key takeaway from this trial. And the secondary endpoints were kept as MPR rate and the PCR rate. So EFS here was at 2 years, it was 62% versus 40%. And the OS, it showed improvement in the overall survival with a hazard ratio of 0.73. And the 2-year OS rate of 81% versus 77%. So even improvements in the pathological complete response of the tune of around 13 to 14%. So to summarize the neoadjuvant immunotherapy, they had better outcomes in the patients in which there is a highest unmet need in the stage 3 patients. Improved pathological complete response also, probably we can hope that it improves the OS also in the trials and the data to come. However, it was secondary endpoint in most of the trials except the Keynote 671, which showed OS improvement. Also, if we see the NADIM trials and the Checkmate 816 trials, the CFDNA clearance was much better in the immunotherapy arms. It could be associated with better outcomes that is under study. The Checkmate 816 trials showed reduced surgical cancellations but neoadjuvant treatment induced downstaging and also reduced pneumonectomies and increased R0 resections. What could be the potential pitfalls of neoadjuvant immunotherapy that we have not been able to ascertain the proper biomarker, so which could predict. So, however, there are studies in the NADIM2 and also in the checkmate that improved immune infiltration. There are various markers of immune profile that could predict responses in a better way in a neoadjuvant immunotherapy setting. Also, there are risk of immunotherapy related toxicities. So, however, because of use of monotherapy and combination, it is much lesser than the dual immunotherapy usage. Now, if you see the adjuvant settings, so there are two main trials, IMpower 10 and Keynote 91. So IMpower 10 used the IMpower 10 was a phase 3 trial which used adjuvant atezolizumab for 1 year after adjuvant chemotherapy in patients with resected stage 1B to stage 3A patients. And here the primary endpoint was DFS and secondary endpoint was OS. So here in patients with PD-L1 positive population of more than or equal to 1%, it reduced the recurrence rate and events by 34% with a hazard ratio of 0.66. And so atezolizumab, as we can see from the forest plot, the benefit was much more driven by the TC score of more than 50%. So atezolizumab is FDA approved for adjuvant treatment following chemotherapy in this subset of cancers with a PD-L1 expression of more than 1%. However, in the European authorities have limited the approval only for up to more than or equal to 50%. So this was an practice-changing trial. And another trial is the adjuvant use of pembrolizumab, which improved the DFS compared to placebo. Is a phase 3 trial, randomized trial in similar subset of population, and the primary endpoint was DFS, and the 3-year DFS rate was 58% versus 50% with a hazard ratio of 0.76. And the further outcomes are still awaited regarding the OS outcomes. However, based on this data, pembrolizumab is FDA approved for adjuvant treatment following resection and platinum-based adjuvant chemotherapy for stage 1B or above, going up to stage 3A. And so what are the potential benefits of using adjuvant immunotherapy? So there is no delay in surgery, no worry of side effects or immunotherapy-related adverse events, acceptable safety profile, and also it gives enough time to recover post surgery and before starting the immunotherapies. So how do we decide which approach to use? Neoadjuvant approach, adjuvant approach, perioperative approach. So the key factors favoring neoadjuvant approach is that the basic principles of neoadjuvant therapy, that it provides early opportunity to eradicate micrometastatic disease, increased treatment initiation rate and compliance, better treatment completion rates of the systemic immunotherapy. Pathological complete response or a pathological response could provide indicator and could be as an important surrogate marker for improving the survival outcomes. Also, we can assess the tumor biology, and also there is a hypothesis that it can potentially eliminate the live circulating tumor cells released into circulation during the surgery. And what are the points going into favor of adjuvant? That allows there is no risk of pre-surgery complications because of systemic therapy, no delay, enables longer treatment duration for systemic control because adjuvant therapy is continued, and more flexible timing post-surgery provides more recovery time for the patients. Again, similar points that for neoadjuvant immunotherapy, the advantage is that it provides more robust and durable anti-tumor response against the micrometastatic disease. That is one of the important factors favoring neoadjuvant approach. And while the adjuvant, it's more related to safety profiles and earlier surgery and the restoring the anti-tumor immune activity after the surgical resection. If we see the guidelines, NCCN recommends both the approaches, while the ESMO currently are recommending both, however, weighing in favor of adjuvant. So, what are the pros and cons of neoadjuvant approach? So, again, reiterating the same, that the pros of neoadjuvant approach is higher antigen load, and by combination of chemotherapy, we have that chance to increase the new antigens and have better response. They are better suited for completing therapy. The treatment completion rates are higher, less concern for toxicity compared to the cytotoxic therapy alone. Increase rates of this is, however, limited only for use of single agent. However, for we are using currently combination based on checkmate 816 data. Increased rates of R0 resection, decreased pneumonectomies, While the negative points for neoadjuvant approach could be delay in surgical resection, a lack of long-term data. However, we are having the data as the trials are maturing. There are some theoretical concerns for surgical complications. However, in practice, we know that neoadjuvant immunotherapy, chemoimmunotherapy is not having much disadvantages when it comes to surgical complications and outcomes. Also, there is a potential risk of progression of disease during the systemic therapy neoadjuvant approach, and also how to deal with hyperprogression and pseudoprogression when these patients have such responses following systemic therapy before proceeding to surgery. So recommendations for this was the American Association of Thoracic Surgery expert consensus, in which they mentioned that for eligible patients with resectable and medically operable stage 2 and stage 3 non-small cell lung cancer without driver mutations, neoadjuvant is the preferred approach over adjuvant based on the data and also according to the expert consensus. So thank you, and would like to have answer any questions if.
Thank you, Dr. Kunal, and the answers will be taken in the panel discussion, because the next panel discussion is on early stage lung cancer. That will be moderated by Dr. Shivam Garg from Noida. And our esteemed panelists are the Dr. Naresh Somani sir from HCG Hospital, Jaipur, Dr. Belavin Asaf, Delhi, Dr. Virendra Tiwari sir, Mumbai, and Dr. Pallavi Purwar from Delhi.
Thank you, Dr. Tarachan. Thank you so much. I'll just share my screen. Just give me a minute. Just thank you. Good evening, Dr. Somani, sir. Good evening.
Good evening, everyone.
Good evening, sir. I don't see Pallavi is there. Hi, Pallavi. Dr. Virendra is here. Hi, Virendra. Hi. Dr. Bilal has joined. He must be joining. Let me just share the screen.
Sir, Dr. Bilal is not there. He is not joining.
He's not joining. No problem. No problem. Right. So thank you everybody for joining in, and thank you, Dr. Tarachan, for this opportunity. I was listening to the previous discussion and just carrying the flow. I think neoadjuvant therapy is the flavor of the season nowadays, and all lung conferences we are seeing more and more this discussion. I had kept a little more basic one. The panelists have changed from a radiation oncologist versus a medical oncologist, from a surgeon to now more of a medical oncologist and a surgical oncologist, because we are seeing more and more neoadjuvant. I am very happy about it. I'm sure our panelists will be. So these are our panelists. Dr. Bilal is unfortunately stuck somewhere, cannot join. Dr. Virendra, he is a faculty at Tata Memorial Hospital in the thoracic surgery division. Dr. Pallavi Purwar, she is another consultant at Gangaram Hospital, and Dr. Somani sir, he's the director of the Somani Hospital at Jaipur. So this is how our panel looks like for today. I'll try to be as fair as possible, but please avoid any biases. I wanted to put a disclaimer slide, but I thought this picture tells everything, so I'll just go with the flow. So Virendra, how would you define early lung cancer for us? We'll start the panel with early lung cancer, just the basics of it.
Hi, Subham.
Hi.
I don't think we have a very clear-cut definition of early CLC. It varies how you deal with. If you say ESTS, they say whatever is operable, even stage 3A is early. But most of the studies have taken T1, T2, N0 to N1 as an early stage NSCLC. And some selected T3, N0.
Right. What about you, Pallavi? Any definition?
I totally agree with Virendra that we're generally taking T1, T2, N0 as early lung cancer. Also, the spectrum is wide, and we need to understand this, that it's not just the T1, T2 that we should be looking at. We have in the T1 also and TI microscopic, and all these are a different spectrum of early lung cancers that we as surgeons are starting to look at much more closely now, because obviously for anything which is going to the T3 or a larger size should be first treated with a lot more therapy than this thing. And I would say that stage 3 as a spectrum we should avoid in early lung cancer totally.
Right. So I think I actually so Virendra, if we were to look at probably a T3 cancer with no nodes, that you'll say would that not be? I agree, it's not early enough, but would its management be different from probably a 3 centimeter lesion with N0 again? Would a 5.5 or a 6 centimeter lesion be different from a say a 3 centimeter lesion management wise?
So, if this was asked around a year or 2 year back, then obviously surgery. But now with so many evidences coming with, immuno, things are changing. Now more and more patients are going or pushed for neoadjuvant therapy rather than upfront surgery. Earlier, the dictum was if the mediastinal stage is N0, N1, upfront surgery. So 5 centimeter tumor or a 3 centimeter tumor, N0 or N1 status would have gone for upfront surgery. But now a T3, that is 5.5, what you are saying, or a smaller tumor involving chest wall, again T3, will mostly in most of the center will be pushed for a neoadjuvant chemo immuno followed by surgery. So obviously management is, there is a paradigm shift.
Wonderful. So I am so happy that we are speaking of more and more of neoadjuvant therapy. But yes, I would agree with both my panelists that initially for a surgeon and even for a medical onc or a radiation onc, anything which is operable was early lung cancer. But we have started paying more heed to the tumor biology now, and we feel that we can do better justice to patients with larger tumors, probably N1 tumors if they have been proven to be. But yes, T1, T2, N0 is the first line to be drawn for early lung cancer. But if anybody would not be wrong if they consider T3, N0 also, which is upfront operable, to be an early lung cancer, because neoadjuvant immuno or a neoadjuvant combined therapy still has to percolate in all centers actually. I'll start with a case. This is a 68-year-old gentleman, ECOG1, never smoker. The CT scan shows a ill-defined spiculated nodule in the right upper lobe. This is the nodule, 3 centimeters. Somani sir, what would be your next investigation?
So in this patient, because primary looks operable or resectable, and looking at the CT scan, it looks there is no gross emphysema in this patient. So there is an intention to do the surgery or resectability. So maybe that we need to evaluate mediastinum. So there are two ways presently which are done. That first we do the PET CT scan to evaluate it, to see the complete picture of the body, plus minus MRI brain. That we can argue in T1, T2 oblique. Otherwise, we do it for the sake of the completion when we have the intent to treat. And second thing is that how to properly evaluate the mediastinum. So based on the PET, sometimes we are guided, maybe the EBUS, maybe the US, maybe the mediastinoscopy, what the skill and what the facilities or the infrastructures are available to our surgeons.
I agree. So sir actually completed the gamut for us. So he spoke about PET CT, he spoke about mediastinal evaluation, he spoke about a MRI brain. Virendra, would you want a PET scan to begin with, or would you want a biopsy to be done first?
It doesn't matter in this case. It's a solid appearing lesion with no much of a necrosis. So in this case, it won't matter. But if it is a larger lesion with necrotic component, then I would like to do a PET and guide a biopsy to a PET avid area. In this, any sequence will not matter much. But I'll need both biopsy as well as PET.
Right.
Can I ask Dr. Virendra one question here? Sorry.
Yes,
can I
sir.
ask the permission?
Yes.
Suppose this patient is clinically NAD, PET CT scan, mediastinum is totally clean. Even if it is the 2 into 2 centimeter tumor, would you like to do the pre-op FNAC biopsy? Or even suppose it turns out to be small cell lung cancer, would you like to straightforward go for surgery?
So for 3 centimeter tumor, I would 100% need a biopsy.
For 2
any
into 2?
tumor, yeah, sir, less than 2 centimeters. So with the evidence for sublobar resection is only for less than 2 centimeter. So if I do a wedge and frozen, and if that turns out to be NSCLC, I can go ahead with mediastinal nodal dissection at the same sitting. So any tumor which is peripheral less than 2 centimeter, even if there is no biopsy, there is a role for a direct surgery where you do a wedge with a good margin. Make sure you get a frozen on table because you have to address node also if it is NSCLC. So in a select situation, you can go ahead, but in most of cases, it is better to be ready with histology because management obviously differs a lot.
So Pallavi, would you ever operate without a biopsy?
No, we would do a preoperative biopsy for most patients, unless, of course, we are dealing with a lesion which is not so solid and it has a large GGO component where we are just doing a localization or it's a very small lesion. Other than that, we would prefer to go for a biopsy first.
And I also feel that now that we are talking about neoadjuvant therapy and we are speaking more and more about understanding the biology, biopsy is getting more and more important because it gives you so much more information about the disease biology, and probably you can take a decision whether to offer that patient neoadjuvant immunotherapy if you have the biopsy in hand. I know we feel it's a solid thing. It would not, probably this was a never smoker, but if it was a smoker patient, everything is in favor of a malignancy, but somehow uh, I am not very comfortable doing a major surgery as major as a lobectomy, which is the standard for this kind of tumor for a patient without a biopsy. So I would always want to do a biopsy, and if now we are even moving towards molecular testing on that biopsy. So I think for me a biopsy is a mandatory. But I think my question was more towards the sequencing of whether we want a biopsy first or we want a PET scan first, because many of the guidelines talk about getting a, and this is more true with the pulmonology community, where they get a biopsy first and then a PET scan done. But as an oncologist, I feel that we should have the PET scan first, which gives us also the area to biopsy, not for this lesion, but in terms of sequencing, we should get a PET CT scan done and then probably get a biopsy done, which is what was standard at our center at least. We got a PET CT scan done first, which showed a significant SUV uptake in the right upper lobe lung nodule. This size was 1.8 into 2 centimeter with no mediastinal nodal uptake, no other distant metastasis, and the CT guided biopsy was suggestive of adenocarcinoma. This is the PET scan picture for this patient. I'll ask the surgeons with me. What further information would you need to decide the management for this patient? We noted about, so again I'll repeat, he's a 68-year-old male, never smoker, no major comorbidities. There is invasive mediastinal staging has already been spoken by Dr. Somani sir. What else do you need? Pallavi.
I don't think we'll need an MRI brain or an invasive mediastinal staging in this patient because of a peripheral tumor which is a PET negative. Having said that, if my center is going on to treating these early patients also with a neoadjuvant immuno, then we would do a PD-L1 panel to look whether the PD-L1 is more than or less than 50%. But otherwise, I would just do fitness evaluation and go ahead for surgery.
So interesting, you spoke about getting a PDL1 done, but before that, would you not want to get a EGF or ALCross done? Because if any of those, markers are positive, we are not even talking about neoadjuvant immunotherapy.
Yeah, so when we'll do the full NGS panel, but I would not offer that to every patient, and I would not say that as a necessary investigation if it is an operable lung cancer, which is peripheral, small, less than 3 centimeter, ECOG 0.
Okay. Virendra, what about mediastinal staging? What's the current status at TMH? What do you follow for a lesion like this, 3 centimeter, no mediastinal nodes?
No, so we right-sided tumor and less than 3 centimeter, no PET avid node, we can avoid any sort of invasive mediastinal staging. We can go ahead with surgery in this case with nodal dissection.
Right.
Can I ask a question here? Can I put my concern as a medical oncologist?
Yes,
or
sir.
let's say that I want to snatch the patient from you. Let's put it straightforward. I
Right.
have done the EGFR in this patient and it's a positive. It's a T2, it's a 2 centimeter tumor. Why not only radiotherapy and then apply the Adura in this patient? Versus giving some neoadjuvant, giving or not giving chemotherapy and doing surgery and followed by applying the Adura. Do you find, is there any real difference? I am talking about the cross trial comparison.
Sir, so I'm just putting your repeating your question just to get the sequence right. If we do a EGFR on the biopsy and it comes out to be positive, you want to give neoadjuvant?
No, I want to do the only radiotherapy in small tumor followed by the osimertinib or adjuvant TKI versus what you people are telling, giving surgery and then applying the adjuvant. Is there any real difference if we talk about the cross trial comparison?
So, but the evidence for so uh, definitive radiation for this kind of lesion followed by a TKI is not that strong. I mean, I'm not aware of that being a practice anywhere where you want to give you want to give Adora or any TKI post radiation for this kind of lesion for a operable disease where probably the everything is fit or patient has not been evaluated. So we need a reason not to operate and then probably consider for a second line of therapy. Why would you offer? Again, probably there's a bias here where I'm coming from being a surgeon, but why would you think in terms of giving radiation where the evidence or the randomized trial does not still show a head-to-head benefit between radiation versus and we want to take the crutches of TKI that TKIs will make up for that reduced survival by giving radiation instead of a surgery. I mean, I am not Virendra or Pallavi. You need to.
Here, I would like to say that if it was an unfit patient, then SBRT would be something that I would think about. But I won't think of a definitive radiation at any stage in this patient, at least based on the current evidence. Obviously, even SBRT, it's evolving, and we are still awaiting to see whether it can really be the gold standard. And I don't think it is there as yet. But yeah, if it was an unfit patient, I would offer SBRT as an option.
Yeah, same here. I agree with Dr. Shubham and Palvi. If patient is fit, lesion is resectable, and obviously with no significant post-operative problems, then we should push for a standard treatment rather than trying something new.
And in addition, I would like to add that even in today's times, the surgery is also becoming more and more minimally invasive. So it's not just minimally invasive in terms of the approach to surgery, which is by a VATS or a robotic, but also the amount of lung resection that we end up doing. In this patient, obviously, if it is 3 centimeter, it's not there. But if it was a smaller lesion, less than 2 centimeter, then even the surgery itself can be as minimally invasive. And we should not think of surgery being a bigger procedure than a radiation at any stage, because radiation can have as much morbidity.
Sir, Dr. Somani, sir, does that?
The idea was just to make the cross-trial comparisons because, as the both panelists, my esteemed panelists said, that unfit patients we do the radiotherapy and SABRT or SABR, they have shown the very good results in their own trial in small tumor. So, and as the trials data are not there where the T1A or T1B are being compared surgery versus SABRT, but if you look at the cross-trial comparison, one can think of offering to the patient that this is another way, though it has not been studied so well.
So that's I think that's where I think we need to change the mindset that why should we offer it to the patient when the evidence is not there. I mean, see, again, I'm coming from a surgeon's perspective that if you tell a patient that surgery is going to be difficult, anybody, even I would want to avoid a surgery. But if we are going to plant it into the patient's mind that surgery, you can probably get away with the radiation, anybody would choose a non-surgical option. So that is for us to decide whether we want to offer it to that. And you yourself are saying because there's no head-to-head comparison, we shouldn't be comparing apples to oranges. And that's where this discussion ends. Sorry to say, but. So I'll just move forward that we have ruled out that we need an invasive mediastinal staging. I have already mentioned that there are no comorbid. This is where the PFT and the cardiac status is something that we need to assess. And this is where the fitness for the surgery is something which comes into the picture. That whether the patient is fit for it or not. We already spoke about what kind of invasive mediastinal staging would you want to know, would we need in this kind of disease. And although both my panelists have said that they would not get any mediastinal staging done for this kind of patient, I personally would get a EBUS done for this patient. That is, again, I am coming from a fact where we have burnt our fingers with getting more and more patients who actually, when they come from the pulmonologist, they already have had a EBUS. So probably not an invasive mediastinal staging. Yes, we have moved on from a mediastinoscopy, but yes, EBUS is something where we would have got done for this kind of patient. I'm happy that we are moving away from this practice, but as an institutional policy, we would have got done a mediastinal staging with a EBUS at least for this patient. I still have this old slide which is still persisting. ESTS has not come with the new format. This is still the 2014 where they talk about getting the nodal evaluation done for tumors up to 3 centimeters beyond 3 centimeters and a node positive. Although this year there was a publication where they were talking about getting away with mediastinoscopy and nodal evaluation for tumors which are less than 3 centimeters. I'll move on from mediastinal staging. I wanted to understand this. What about MRI brain for early lung cancer, Pallavi? Would you get a MRI brain done for this patient?
Actually, as an institutional policy, we generally do an MRI brain. But yes, a very small peripheral tumor, the guidelines do not recommend. They say that
What is
may
very
or may
small
not be done.
peripheral tumor?
We do it.
What is
We do.
very small peripheral tumor? Size?
I mean, any tumor more than 2 centimeter size, we are doing an MRI brain at our institute.
So 2 centimeter means 1B, right? At least
Yeah.
T1B.
Yes.
Virendra, what about you?
Adenocarcinoma and T1C, we should do MRI brain.
T1C, 2 to 3 centimeters.
Yes, and adenocarcinoma histology.
And adenocarcinoma. Yes,
Yeah,
agree.
yeah.
Somani sir, what about you?
So if any patient, if we are subjecting them for the local treatment, I think the mediastinal and the brain MRI evaluation should be done. That's a medical oncologist perspective.
No, sir, I completely agree. I think you have hit the nail, the nail on the head. That, you know, definitely, I completely agree that for a surgery, for a procedure as big as lobectomy and that too a thoracic procedure, I would also want to get mediastinal staging with the EBUS, at least a EBUS, and also get a MRI. Now, this evidence again, it shows that the yield is only substandard for diseases which are stage 1A, which is less than 2 centimeter. Probably you can get away by not doing a MRI brain because the chances of picking up is very small, being less than 2 centimeter. But anything above 2 centimeter, you should get a MRI brain done. And again, still there's no evidence, but we have had surprises where we have 3 centimeter lesions with a single met being picked up in the MRI brain, and these MRI brains are all done with contrast so that you are able to pick even the smallest of the nodules. So I think what Pallavi and Virendra said, that they would get a MRI brain for any lesion which is more than 2 centimeter and probably not for anything less than 2 centimeter, but also what Virendra mentioned, that they all have to be adenocarcinomas. For squamous, you will get for any lesion, right, Virendra?
No. So T1A, T1B squamous we can avoid, but T1C and adenocarcinoma histology, which are more, can have a brain metastasis, in those cases we will do.
So you mean to say adenocarcinomas, any size you will get a MRI brain done? Any size?
Yes.
Oh, sorry, I mistook you. Okay.
So talking this adenocarcinoma is more related to the mutation. And we all understand the all available studies in the advanced mutation patient, there is a higher chances of the brain mets at the time of the presentation and during the course of the progression of the disease
Even
also.
when the tumor is very small.
And probably that applies to the adenocarcinoma little earlier stage also.
Yeah.
And in squamous patient, usually we don't get the mutations. So that is the maybe the differential reasons that the adenocarcinoma patient, they have little higher chances of getting the mutation positivity. So any patient, if we are subjecting them the definitive local treatment, I will be going for the evaluation of the patient in a complete sense.
Agreed, sir. Although we have already spoken about it, but who, amongst the 3 surgeons, are we actually getting this molecular testing done on our biopsy specimens right now, Pallavi?
Actually, for us, I mean, since in the private sector, sometimes it's not very easy to subject every patient for a full molecular panel at the biopsy. But yeah, I mean, if ideally I would like to do an EGFR AL cross and a PDL1 on a biopsy. But yeah, we are not doing that as a routine practice because of issues with the. I mean, if we are going ahead with the surgical management, then we generally send the main specimen for the same.
What about Virendra? Is
Yeah,
there a policy?
same here. Not in all patients. Patients who are being planned for upfront surgery, it is not being done.
Okay, so the lab is not offering it as a. Okay, so
Yeah.
Dr. Kumar is not picking up those specimens right now. Okay, okay. What about you, sir, Dr. Somani? Are
If
you?
upfront surgery is being planned for individual patient, then it may not be mandatory, but rather it will be I will say, the wastage of the time and the money, because the tissue may be an issue, it may be incomplete study or inadequate information. So once the surgery is done, you have the better tissue availability, so to go for that. But suppose the tissue, the staging is something like the stage 2A or 2B or something like 3A, where you are thinking of giving the neoadjuvant chemo plus minus IO, then it is probably the mandatory to go for the these tests, and maybe the quicker method like the PCR versus method like for the EGFR and ALK may be the required to exclude the patient, so that we can include them for the IO arm of the treatment.
Okay. So, sir, I'll just come back to the previous question which you actually asked, that if a medical oncologist wants to take away the patient from the surgical oncologist, probably this is the time where you can actually get a EGFR AL cross done and prove that this is the patient who will actually benefit from neoadjuvant therapy. Because as surgeons, we all accept that our patients always get distant metastasis. They are very rare chances of local recurrences. We always lose the battle to distant metastasis. Am I right, Pallavi and Virendra?
Yes, yes.
So we are all. Pallavi, you want to say something?
I just want to say that I don't think that either ways anybody snatches the patient. We work as a team, and ultimately after neoadjuvant, the patient is going to come to us. So I think that's one thing.
I agree. So, but I want to increase the number of patients which are going for neoadjuvant, because then it increases my survival. So I think, sir, बताइए ना sir, कुछ कह रहे हैं आप?
Yeah, if we go through the presentation of Dr. Kunal, he has repeatedly stressed upon the pros and cons of the neoadjuvant versus adjuvant. The idea of the individual trial is to show the benefit in that particular setting, like chemo versus chemo plus IO in neoadjuvant setup. None of these trials have shown the real differences between the neoadjuvant followed by surgery versus surgery followed by IO or EGFR approach. So we really don't know in a given situation in a patient like the 1B or 2 that what is the best for the individual patient. We can offer them the neoadjuvant followed by surgery. We can offer them the upfront surgery in a good selected patient followed by based on the EGFR, based on the mutation negative. So we really don't know that how to approach the patient. That is my feeling.
Right. But I felt the Checkmate 816 showed a very good DFS data, and also the PCR rates were so good that actually I also feel that they should go for neoadjuvant, because if they live longer, it is always in our benefit as even for surgeons that we should. So I actually promote my patients to get the molecular testing done, not for the reason that we would, but if I am able to pick up that subset of patients who I can offer neoadjuvant immuno, I would be very happy to do it. Obviously, there's a cost involved, and we always discuss the cost. We would not even offer it to a patient who's financially so challenged that even a biopsy is the issue. But as a practice point of view, I think we should get molecular testing done on our biopsy specimens. If we have actually crossed this road, that what's the ideal treatment in early medically operable lung cancer, I'll just skip this. We are 5 minutes left for us. What's the ideal surgery that we can offer to this patient? 3 centimeter lesion, peripheral, Virendra?
Lobectomy with the nodal dissection. Systematic nodal dissection.
Right. So this is the right upper tumor. We should offer a right upper lobe systemic mediastinal lymph node dissection. Pallavi, what systemic mediastinal lymph node dissection means to you?
Systematic mediastinal lymph node dissection is removing the lymph node packet in all these stations while we are there. See, obviously the contralateral we cannot approach unless we do a mediastinoscopy, but on the ipsilateral side, we'll take the 2B, 2R, 4R, subcarinal, precarinal, paraesophageal. So yes, I mean, the bare minimum is those three stations, but for us, it would be removing the entire lymph node packet in all the nodal areas.
Right. So this is what the bare minimum that we have to take out 2 or 4 or 7. But as Pallavi said, we also have to take into consideration the paraesophageal nodes, the nodes along the inferior pulmonary vein, station 9, and if possible, the pretracheal nodes also. Uh, we have already again discussed this neoadjuvant therapy for early operable lung cancer. Potential benefits of neoadjuvant therapy. I personally feel that it is for the good, that it helps us in understanding biology of the disease. It gives us the time to prehabilitate the patient. We also understand the pathological responses for better assessment and as a surrogate survival, and somehow systemic therapy is better tolerated. I have not seen this, but they say it. Okay, this is where the question I want to get from Pallavi and Virendra. But once you are given neoadjuvant therapy, especially the neoadjuvant IO, what problem that one may face on table? Virendra and Pallavi, first Virendra, then Pallavi. Have you operated patients post neoadjuvant IO?
Yeah, we have done 4 cases.
Okay.
And what everybody says, I think we have also faced. So if nodes were positive and they have responded to immuno, it is very difficult to dissect those nodes out of a pulmonary artery. So nodes that are along PA, they becomes little sticky and dissection becomes difficult and it is little more oozy, but not impossible kind of. So that difficulty we have faced. We have seen only 4 cases, a long way to go. But yeah, that is the problem.
So would you have more conversions from a minimal access to
No.
able to do it completed
Yes,
minimally?
yes,
Okay.
yes.
What about you, Pallavi?
So at our center, we've done cases with neoadjuvant immuno. And what I would say is that, yes, it's slightly more difficult, but what I felt is that with the most of us operating with TB cases as well, it's I think the challenge is somewhere between the TB cases and the early lung cancer cases. I won't say that it does not exist. And yes, we have had conversions. I mean, for us, sometimes we've had to convert, but it is possible, and it's all as a learning curve, we'll grow. Robotics, we've not tried much, but both VATS and open, we're able to get out with it. But yeah, it's slightly more challenging than usual, not as challenging as the aspergillomas.
Okay. Any problem in creating fissures, and any problem in the parenchymal side, or it is just the nodal side that you feel?
Node, mostly node.
Mostly
Actually, we are doing fissure-less lobectomies now. Mostly,
Right,
I mean, at least
right.
at our center, our preference is to go for a fissure-less lobectomy. So it's mostly the nodes that cause the problem, and at the end, you just staple off with a stapler. I mean, those staplers have really changed our lives.
Right. I agree. So my issue is that I had to convert 2 of them because of the fear of bleeding that we needed to convert. We didn't want to end up in a situation where we end up with a major bleed. That was the only problem that we faced with the nodes. They were sticky. We were not able to get it, and they were also very vascular. And that is where the response comes because of the increased immune responses, that the nodes become stickier and more vascular. And then once they start to bleed, it's difficult to control, especially if you're not in the right plane, because once the node starts to bleed, it's difficult. If you get into the right plane and the node starts to come up, then it comes out nicely. But if you're not able to, then it's very difficult.
Yeah, we've also converted. I think it's always good to be safe for the patient.
I know. Otherwise we'll prove Dr. Somani sir right that surgery is more dangerous for the patient. So that's why we convert, sir, whenever we feel that there's a challenge.
So can I ask
yes,
a provoking question to all my panelists?
Definitely, sir.
Stage 3A and 2, because of N2.
Hanji.
You want to go neoadjuvant followed by surgery, or you want to treat the patient like CTRT followed by consolidation IU like Archer? What's
So
your
I
gut
so
feeling? What's
so
your gut feeling?
I have so many questions about this N2, but I'll ask Pallavi. I'll let Pallavi and Virendra. Dr. Tarachand, आप कभी भी रोक सकते हैं. We are just going off topic, but just let
No,
us know when you.
I am enjoying this
हाँ
session.
जी
That's
हाँ जी
why
good.
and learning many things of
नहीं
surgical
नहीं नहीं
aspect.
आप whenever you say we'll cut it short. We have
Yeah,
almost
that's why I
ended.
am not interrupting also
Thank
anytime
you,
because I am just
So
listening
so
everything.
let me start with Pallavi. Pallavi,
Single
N2.
station N2 new. I mean, single station N2 or operable T3 N2 is something that I would think of doing a neoadjuvant and followed by response assessment. If there's good response and operable still, then go for surgery. Otherwise, CTRT. And if it's
So
like a bulky multi-station N2, then I would sometimes lean towards a upfront CTRT.
okay, so you mentioned two things. You mentioned about single and bulky, and you also mentioned response assessment. So
Yeah.
it means that you want to give some neoadjuvant therapy.
So that's what I said, that if it is a bulky multi-station N2, then I might not even do an NACT. But if it is a single or a non-bulky N2, T3 N2 disease, then I would do neoadjuvant therapy followed by response assessment. Followed by
Okay,
a
hold on to that.
CTRT if it is
Hold on to that.
inoperable at
Hold
that
on to
point.
that. Anything else, Virendra, you want to know about the patient? So we spoke about the number of nodes. We spoke about the bulky, non-bulky. Anything else? What neoadjuvant therapy would you consider, or would you not even consider neoadjuvant therapy? Send it directly for CTRT.
No, it's in stage 3A, we'll consider for NACT and will prefer if patient is affordable for neoadjuvant chemo plus immuno, because downstaging is better, PCR is better. And what Pallavi said, single station and two resectable, yes, neoadjuvant chemo plus minus immuno, and go ahead with the response assessment and operate patient.
Okay.
Another scenario is sometimes lower lobe malignancy. Yeah, so lower lobe with higher paratracheal. Maybe a multi-station like subcarinal plus 2R in a right lower lobe. It may be difficult for a CTRT. In such scenario also, it is neoadjuvant chemoimmuno if nodes are resectable, and then do a response assessment and go ahead with surgery.
You know, Virendra, in real world, no radiation oncologist says that this is difficult. Sir is laughing because sir knows the truth. So again, define bulky for me, please. Virendra, what is bulky nodes?
Anything which is infiltrating adjacent structure, like if the node is infiltrating your esophagus, or it is infiltrating pleura, or it is infiltrating bronchus, or if there are matted adenopathy, or if the node is more than 3 centimeter size, those will form a bulky definition of bulky.
Right, sir. So, sir, let me just summarize this for.
I request you to conclude in the next 2 minutes, please. We are running out of time.
We are finishing, Yashika. You just hit the nail at the right time.
Okay, sir. Okay.
Don't worry. So, just to summarize, sir, for us, it is not enough to say that this is stage 3 or this is N2. As a comprehensive evaluation, we would need the number of stations which are positive, the size of nodes, and now Virendra has also mentioned about the location of nodes, which I had not considered actually. But I think for us, the dictum is that if this patient is definitely going for neoadjuvant therapy, but if it is multi-station and bulky N2, and although Virendra was very generous when he said about 3 centimeters, I take it as actually 2 or 2.5 centimeter as bulky nodes. But for us, we would not consider these patients for surgical resection if they were multi-station and bulky nodes, as Virendra said, infiltrating in nature. Because even if they respond, probably we will not get away with a good margin, or the disease biology is such where we cannot justify a major surgery for such patients. That is why. But if it is a single station, then or a non-bulky nodes, then definitely neoadjuvant is the way to go forward, and then to consider for surgical resection. And even the AJCC, the new one, has taken into consideration whether it is single station. So they have divided into N2A, N2B now, where they talk about single station, multi-station. So that lingo is actually coming officially now, and not out of a conference, where they are officially talking about multi-station and single station. We won't go into sublobar resections. We all of us have accepted about need for SBRT or a non-surgical intervention if this is not surgery patient is not medically fit. I think for medically operable, I'll just conclude by giving this last slide. Medically operable patients, lobectomy versus sublobar resection is where the question is still hanging. We need more evidence. I think for tumors less than 2 centimeter, the two trials for SBRT still awaited are this. For medical inoperable, SBRT is definitely way forward. Can we offer them a sublobar resection? Again, this is something which a hardcore surgical thoracic surgeon would be able to be after. But molecular biology is the king. We all agree that targeted therapy is here to stay, and neoadjuvant immunotherapy may have a very impactful role in the near future. I am very hopeful for this because I feel as surgeons, we are already doing our best to improve the survival, but we are bound by the systemic disease rather than the local disease. Hence, I am very hopeful that neoadjuvant immunotherapy will do the change what neoadjuvant therapy has done for breast cancer. With this, I thank everybody, especially Dr. Somani sir, Dr. Pallavi, and Dr. Viren. Dr. Viren is still in OT clothes at Tata, so best of luck for him. It's 8 o'clock already. Okay, thank you, Dr. Tarachan.
Thank you, Dr. Shubham. Thank you, Tarachan.
Thank you, Dr. Shubham, for a fruitful and wonderful discussion. Now I invite Dr. Manoj Mahajan for a talk on vision for MAT-X14 skipping skipping mutation in NSCLC patient. Dr. Manoj Mahajan, over to you, please.
Am I audible?
Yes, you are audible.
Yes. Just share the screen. So my screen is visible?
Yes, visible.
So this vision for METXL stands for the vision trial, which was done in METExon 14. So today's objectives are to, as I was listening to the previous lectures. So now from early to metastatic disease, and from metastatic, we are moving from EGFR, ALK, now we have reached to METExon, which is now being discussed quite commonly in the conferences. Just a disclaimer, I haven't used any of the METExon inhibitor as of now. So we'll be discussing the data, whatever is there. So importance of the testing and the management of these patients and the current guidelines that we'll be discussing. So what is the disease burden, as earlier speakers have spoken about it? I'll just briefly go through it. The global incidence is around 22 lakhs and constitutes around 11% of the patients, and deaths are quite severe, like almost 18%. And in India, new cases are to the tune of 5.5%, and deaths are almost double, around 8%. So it accounts for 8% cases in males and 3% in females, second most common cancer in males versus 7th in the female. So NSCLC accounts for nearly 80% of the lung cancer cases, with adenocarcinoma being the most common histology. So coming to the METExon, skipping alterations. So there are two types of alterations, usually METEX14 amplification and METEX14 skipping mutations. So with this alteration in the MET gene, including METEX skipping, it disrupts the MET signaling pathway. How does it do it? It results in the MET protein, which is lacking the juxtamembrane domain, which is responsible for MET ubiquitination. So that is how it increases the number of MET receptors on the cell surface, and these are not degraded. And the increased MET signaling drives the oncogenesis. So as we know, these constitutes nearly 3 to 5% of the patients of the NSCLC. Majority of them are adenocarcinoma. As the NCCN guidelines depicts, in all the histology subtypes, irrespective of the squamous or non-squamous, METEX14 skipping mutations have been recommended, though we commonly see all these mutations in non-squamous subtypes. So biopsy methods, still the tissue biopsy is the gold standard, and the alternative liquid biopsy is coming up. So usually with the tissue biopsy, we can go for the IHC FISH and then RT-PCR and broad NGS, broad panel NGS. For liquid biopsies, which usually sampling is done and circulating tumor-free DNA or CTC are isolated, and then they are subjected to RT-PCR and NGS to evaluate the METEX skipping mutations. So ATORG, that is Asian Thoracic Oncology Research Group, consensus has recommended doing a METEX 14 skipping mutations in the advanced NSCLC. They have suggested RNA-based methods are more accurate as compared to the DNA-based. So again, coming to the biopsy options, we are dealing either tissue biopsy versus liquid biopsy. Tissue biopsy is still gold standard. Liquid biopsy has improved sensitivities. So there are just few comparisons of tissue biopsy versus liquid biopsy. The acceptability of the tissue biopsy is moderate. Liquid biopsy, it is quite easily available. Invasiveness is quite high for the tissue biopsy as compared to the liquid biopsy, just a simple blood draw. Risk of complication is much higher, especially the occurrence of the tissue, if the tissue is limited to primary lung or near the mediastinal structures. And there is hardly any risk in the liquid biopsy per se. The sensitivity is definitely higher than liquid. That is why it is a gold standard. The targeted collection is possible in the tissue biopsy, and we take the there is no targeted collection in the liquid biopsy. Liquid biopsy is suitable for all, but it is not possible in all the patients, especially the patients are frail, patients are not willing, or the disease location is in the critical location. Then it becomes difficult for a tissue biopsy. So coming to the treatment landscape, so as MET exon 14 skipping mutation, the trial showed chemotherapy versus MET inhibitor. Median OS for the chemotherapy arm was 8.1 months versus 24.6 months. It was quite significant with hazard ratio of 0.11. So it's probably one of the impressive hazard ratios in the lung trials. The MET exon 14 skipping NSCLC have shown quite higher incidence of high PD-L1 expression or even the higher TMBs, but the response to such tumors is very poor. So if coming to there is a limited response to immunotherapy, 24 patients trial, waterfall plot is showing nearly overall response rates of 17%. It's very poor as compared to what we see in other tumors, as compared to the MET inhibitors who achieve nearly 66% of ORR. And again, PFS and median OS with the immunotherapy is minimal, like 2.7 months versus 12.3 months. As compared to the MET inhibitors, which was median PFS is 15 months versus 30 months. So it's it's not the direct trial comparison, but the data to share. Probably the larger trials will exactly answer all these questions. So as per the current guidelines, ISMO and NCCN guidelines, for MET exon 14 skipping metastatic NSCLC, preferred first-line treatment is tepotinib or capmatinib. In certain, crizotinib can be used in certain situations. So comparison of the tepotinib, capmatinib, and savolitinib. So we can see there are 3 trials for tepotinib: vision trial, capmatinib geometry trial, and savolitinib. So it enrolled nearly 300 patients, 160 patients, and 70 patients. The brain penetration, if you can see, of the tepotinib 25% as compared to the capma 9%. So definitely tepotinib, we expect a better CNS results. So tumor shrinkage with the tepotinib has seen nearly 86% of 6 interanalysis and control rates that nearly 70%. So dosing is 2 tablets a day. In first line efficacy, overall response rate, if we look at the Asian subgroup, it has both the tepotinib and capmatinib has shown nearly 66% the response rates. Median PFS year or more than a year. Median OS not reached in the tepotinib arm versus capmatinib. In capmatinib, it was 25 months. If we look at the efficacy in second line setting, again, it is matching nearly 40 to 50%. Median PFS nearly a year with the tepotinib. Median OS is around 20 months with tepotinib in Asian subgroup. Grade 3 adverse events were higher in tepotinib 29.6%, and discontinuation rate was also higher, nearly 15% patient as compared to the capmatinib. So the vision study is a single arm phase 2 trial tepotinib in patient with the NSCLC harboring MET exon 14 skipping mutations. So main inclusion criteria advanced and metastatic
Dr.
NSCLC.
Manoj, request you to conclude in the next 2 minutes, please.
Yeah, I'm about to finish. So this is the landmark trial where cohort A, cohort C are mainly MET exon 14 skipping mutation, and both cohorts were given tepotinib. So we'll just go to the few results. Tepotinib efficacy in treatment naive patients. Median OS was more than 2 years. Median PFS more than a year. And in patients with previously treated patients enrolled by tissue biopsy, median PFS is less than a year and median OS is less than 2 years. So even in previously treated patients, tepotinib has good results. This is the comparison. I'll just flip through few adverse events. These are the few safety profile. If you look at the safety profile, main side effect profile is nearly 66% patients had peripheral edema, 60% patients. And other side effects was hypoalbuminemia, blood creatinine increase. So peripheral edema is usually grade 3 or severe in few patients, but every alternate patients will have edema. Elderly patients have a more propensity to develop the edema, and it can be managed conservatively and preemptively. So we have to be very cautious measuring the limb circumferences and starting the diuretic for such patients. There is also one side effect which is quite pronounced, like blood creatinine increase, grade 1, grade 2 creatinine increase seen in nearly 25% of patients, where we may need to reduce the dosages of the tepotinib. Thank you. Just
Thank you, Manoj,
yeah.
for discussing this rare mutation. And yes, is seen rarely, and nowadays that taken.
Yeah, thank you. I think Tarachand, you kind of broke up over there.
Hi,
Yeah.
Arun.
Yeah, okay. So thank you, Tarachand, for this opportunity, and best of luck with the meeting. We'll quickly just run through the current management of EGFR exon 20 insertion mutations in the next 10 minutes. So we know that non-small cell lung cancer is not one disease, it's multiple diseases with multiple, one second, let me just take this. Yeah, with multiple subtypes and molecular subtypes which have separate treatments. And the current status of management of this molecular-driven non-small cell lung cancer is very vast, with new molecules being added every 2 months or so. And what we're going to specifically talk about is EGFR mutation. And EGFR mutation, the most common is exon 19 and exon 21. And the third most, in around 12.8%, is exon 20 insertions. Now, these are usually resistant to the standard EGFR TKIs. However, there are new drugs which are being approved today. So the clinical characteristics of exon 20 insertion is very similar to EGFR group of patients. They're mostly non-smokers. Common metastasis is there in the brain as well as in the bone. Now, the outcomes of this group of patients is dismal and much inferior when you compare it with exon 19 and exon 21. So that's definitely an unmet need for these patients. So first, we'll be discussing what used to be the treatment for exon 20 insertion. There's been retrospective studies which said that chemotherapy plus bevacizumab has some effect in the first line and more pronounced effect in the second line treatment of these patients. So chemo plus bev was largely used by a lot of people. With the advent of immunotherapy, the trials which looked into the usage of immunotherapy in this subgroup were done. But as you can see from the graph, the results were quite dismal. Exon 20 insertions, like every other molecular-driven oncogene cancer, does not respond to immunotherapy. And after that, they even tried the conventional EGFR TKIs, but here also, in this group of patients, it failed quite badly. So because of this, there was increased need to look for novel treatments in this group of exon 20 insertion non-small cell lung cancer. First, they took osimertinib, doubled the dose and gave it to the patients. And there was some response with an overall response rate of around 25%, decent disease control rates and a PFS of 9.6 months. But there was a feeling that things could get better. So that's where the first drug which was tested was poziotinib, which was tested in both exon 20 insertion, EGFR and HER2 exon 20 insertions as well. So this was the Zenith 20 trial, and it did not show much benefit. The response rates were hardly 17% in EGFR and around 25% in second-line HER2. So the FDA in 2022 straight away said that this was a bad trial. Poziotinib should not be used in EGFR and HER2 exon 20 mutation. So the exact words is that the company tried to build this drug like building a castle on quicksand. So the trial was poorly designed and it was toxic and did not have any effect. So the second drug which then was tested was mobocertinib, and this was tested in a phase 1-2 trial where they took patients who had progressed post chemotherapy and gave them this oral drug to see whether they would respond. So here there was a little more better overall response rate around 32%, duration of response 17 months, and a PFS of 7.3, which was not bad. And based on this, the FDA gave the approval for mobocertinib in September 2021. But they said that you have to do a confirmatory phase 3 trial to show its efficacy. And this was the phase 3 trial, which was the XClaim-2, where they took upfront, that is treatment naive patients with exon 20 insertion, and gave one group mobocertinib and the other group they gave chemotherapy as standard. But however, this trial, it's not published, but they just put out the results. It did not meet its primary endpoint of PFS. And the FDA and Takeda, which is the company, are withdrawing this drug from the market. So it's lost its FDA approval. And this just happened last month on October 3rd. So it got approval for around 2 years, but now it's out of the market. So the third time is lucky, as they say, and the third drug was amivantamab, which was developed simultaneously with mobocertinib. And this is a bispecific antibody targeting EGFR and MET. It has 3 mechanisms of action, which you can see here, which degrades the EGFR receptor, increases the immunity, immune cells attacking the cancer cells, and inhibits the EGFR from binding to the EGFR receptor. So this was the Chrysalis trial, which was a phase 1-2 trial where they found out the dose of amivantamab, and they took patients who were post-chemotherapy with exon 20 insertion, gave them amivantamab, found out the dose of 1050 milligram, as 3 vials was the standard dose, and they tested its efficacy. And here they found out the response rates were around 40%, which is slightly better than the previous drugs, with a duration of response of 11 months. So this was not bad. And based on this, again, the FDA gave an early accelerated approval to this drug in exon 20 insertion mutations. But these patients had to have received prior platinum chemotherapy. So once you get approved in second line, the next bandwagon to jump on is the first line therapy. So this was the Papillon trial, which took patients who were treatment naive and gave one group amivantamab plus chemotherapy and the other side received chemotherapy alone. And this trial got published in NEJM in October 21st last month. And if it's published in NEJM, we obviously can say that this was a positive trial. And the the primary endpoint was PFS, and amivantamab improved the progression-free survival 11.4 months versus 6.7 months. That's almost double, with a hazard ratio of 0.4. So that's put more faith into the drug. And Johnson & Johnson has applied for the FDA approval, although it has not got the FDA approval as of now. It is in process. It was submitted in August. So most probably in the next 1 or 2 months, we should see the approval for amivantamab plus chemo in the first line. But as of now, it is not FDA approved. So the only drug as of now, which is proper FDA approval, is amivantamab in the second line setting post platinum chemotherapy. Mobocertinib was there. This was the old slide which I got from CCO. So mobocertinib has now been withdrawn. It's out of the, it's being pulled out of the market. So you have in this segment only amivantamab right now. So to summarize, if you have an EGFR exon 20 mutation, first line, you have a patient, you can use chemotherapy plus minus bevacizumab, that's your choice. And if the patient is rich and understands this drug is not FDA approved yet, based on the trial findings, you can offer amivantamab plus chemotherapy. In the second line post-chemotherapy progression, you have amivantamab as a single agent, which is FDA approved, and if the patient has no money, go for chemotherapy plus bevacizumab. Thank you.
Thank you, Arun, for talking about this rare mutation and rare drug, and lucky drug which got approval after the withdrawal of the various FDA approvals of other drugs. So, but I have not used this drug till now. Now I invite Dr. Deepak Shukla for a next talk. He is a senior medical oncologist in Manipal Hospital, Jaipur. He will be speaking upon dual checkpoint inhibitors in first line metastatic non-small cell lung cancer.
Support team, please stop the recording.
I think, sorry, I skipped that. Dr. Abhishek, sorry.
Okay.
Sorry, Dr. Abhishek. I invite Dr. Abhishek from Jodhpur. He will be speaking upon management of NTRK ROS1 mutation non-small cell lung cancer. Dr. Abhishek, over to you, please.
Please share my slide or allowed me to share.
Support team, give permission to doctor for sharing the screen.
Okay.
So you can share your screen.
Okay.
Dr. Abhishek, are you able to share your screen?
Yeah, I'm doing actually.
Okay, so can we?
Yeah, I already sent you my
Yeah,
PPT.
Yashika, Gitika, any one of you have doctor's slide can share?
At mail actually.
Yeah, sir. It's there.
Okay. Thank you. So good evening all. So I am actually discussing the management of the NTRK and ROS1 fusion in advanced small cell, non-small cell lung cancer. So next slide, please. Yeah. So we already discussed about the more common mutation EGFR, EGFR, MET, or already we have the discussion. Now I've discussed some uncommon mutation, which I discussed is a ROS and NTRK infusion. So basically, we have tested the ROS infusion by the FISH testing, multiplex PCR testing. We have NGS. We can go through a DNA sequencing or RNA sequencing. Next slide, please. So this is a ROS1 infusion. ROS1 infusion appears to be a molecular subset susceptible to a targeted inhibition. Many partners, most common partner is CD74, and it's mutually exclusive with the EGFR and ELK and RAS. And the produce the oncogenic protein is the ROS1 kinase protein. The mechanism of activation is unknown. The breakpoint in the FISH we found is exon 32, 34, and 35. So this is the breakpoint part of the ROS fusion, and this is more common in the never or light smokers, on a younger age, on adenocarcinoma subtypes. The mechanism by which the ROS1 infusion is activated is still unclear. Slide, please. So this is a journey of ROS1 TKI approvals. So in the first line, we got approval with the crizotinib in the July 21, 2016, in the both words, Eastern and Western words, and later on crizotinib on Eastern word, and later on entrectinib is the in 2019 and 2022 we found the entrectinib approval for the ROS1 TKI globally. So in a first line, you can say you can use crizotinib, and the is in a recent one, the entrectinib is approved for the ROS TKI. Slide, please. So this is the available ROS TKIs. Two approval in the first generation is crizotinib and entrectinib. One you can off-label use is Ceritinib. Second off-label use, second generation is Lorlatinib and Cabozantinib. And development in lesion is Repotrectinib and Taltrectinib and NVL 522. So I discuss in brief all these TKIs. The response rate of ROS1 inhibition with the crizotinib is 72%, with the median PFS around 19 months, with the median duration of response is around 71. Most side effects is visual impairment, diarrhea, nausea, edema, constipation. So it's all are manageable. Next slide, please. Next is entrectinib. Entrectinib has a almost same response rate is around 77%, with the same median PFS is around 19%. But the positive part is the CNS. Those patients who have a CNS metastasis as a presentation, the response rate of entrectinib is 74%, with a good median PFS around 13.6 months, and the duration is response is around 12.6 months. So entrectinib has a good activity those patients who have a CNS metastasis as presentations. Next slide, please. This is a Ceritinib. Ceritinib has a almost same response rate with the lower than the crizotinib and the entrectinib is around 67%, with the good PFS, with the duration of response is almost 21 months. So, but the CNS activity is very minimum with the Ceritinib. Next slide, please. Lorlatinib also has a response rate around 62%, with a good PFS, and with the compared to the crizotinib, there is a good intracranial response also. Slide, please. So this is the summary or the TKIs, those who are approved in a first generation is a crizotinib, second generation is entrectinib. You can say the response rates is the 72% and 77% with the crizotinib and entrectinib, with a good PFS 19 months, with the duration response around 2 years. So in the those who are, this is approved TKI, but those who are unapproved but still some we are using is a Ceritinib and Lorlatinib, with the response rate is around 60% and with the PFS is around 19 months. Next slide, please. So this is the we summarize. We can use entrectinib or crizotinib and entrectinib is the first line, and we can use as a unapproved with the Ceritinib or Lorlatinib. But the most common mechanism of mutation resistance to crizotinib is the ROS1 G2032R. This is the most common known resistance mechanism by a first for a crizotinib. 55% is unknown for any resistance, and other one is some uncommon ROS mutations, MET amplification, NF1 loss. Next slide, please. So some are the new generation TKIs, those who are actually work against this resistant mechanism G203. So the Repotrectinib is used mainly after the prior TKI, and you can see the response rate is around 37% is the response rate when we use the Repotrectinib is the first after any TKI. So definitely it's a good drug. So because in the second line you can use this drug, is still in phase second trial. Next slide, please. Yeah, so this is the CNS activity of this drug. You can see in this chart, there's the intracranial efficacy. The overall response rate is around 87%. Those who are received Repotrectinib in a NAPE patients, and those who are received already one TKI, the response rate is around 47%. And it has a good activity in the CNS also. So the response rate in CNS is also good with the Repotrectinib. Next slide, please. Yeah, so Repotrectinib used in this phase second data is a Trust China trial, or you can see the overall response rate and overall intracranial response rate is actually good. Their PFS and their duration of response is still not reached. So we have to wait for the final result. But yes, the result in the phase 2 with the response rate is promising. So look on the future. Next, let's see. So next is one more drug is MBL52, the phase 1 ADO trial. You can see in the response rate is good with the ROS1 2032 resistant mutation, those who are CNS metastasis and prior TKI also. So definitely we have to wait on other more phase second or phase third studies to these drugs. Yeah, definitely. Next slide, please. And this is a CNS safety data. You can see overall response rate is around 73%, and no still side effect is still not we found any grade 3 or grade 4 side effect, but we have to wait for the data. Next slide, please. Yeah, so this is a second generation TKIs who are in developing phase is a Repotrectinib. You can see is around 38% response rate, PFS not reached, at 42% CNS activity, and those are mutation is a 2032 is 59%. Is the second one is the taletrectinib. You can see is 50% response rate, PFS not reached, 92% is CNS activity, and 80% activity in the mutation. This is a NVL 520, the same response rate, same CNS activity. So that's we have to look their side effect is also quite manageable in these trials on a phase 3 trials, but we have to wait. We have to found these drugs. So after phase 3 studies. Next slide, please. So now I move to the TRK families. So this is definitely 3 receptor in we found is a 1, 2, 3. Basically, they are a neurotrophin family. They are mainly regulate for the pain and thermoregulation. 2 is for the movement, memory, mood, and appetite, body weight, and third for the proprioception. And they their ligand binding domain replaced by the 5 fusion partners drives overexpression and ligand independent activation. So TRK uncommonly expressed in the normal tissue, but the cancer cells definitely abnormally high expression and activation of TRK kinase domain. Next slide, please. So this is the TRK around 1,500 to 5,000 patient harbor TRK fusion positive cancer in the US is annually. You can say in the red arrow, there's some rare mutation. Those have a high frequency of the TRK fusion, but there are some common cancer, those who have a low TRK fusion frequency, but you can find any TRK fusion in any cancer. So definitely we have to talk about the TRK fusions. Next slide, please. So the first drug is larotrectinib. This is approved in 2018 for adult and pediatric patient, those who have a TRK fusion in a solid tumor. Number of patient is 153. The response is good as around 80%. With the median duration response is also good, is around 35 months. And those who are patients in the CNS mets around is 12, not so high, but the response rate is good in the patient those who are a CNS activity, CNS metastasis. So response rate is 75% in the those who are a CNS metastasis. Next slide, please. Yeah. Next is an entrectinib. Entrectinib approved in 2019 for the both age groups, adult and pediatrics, with the NTRK infusion, as well as the patient with the ROS1 and non-small cell lung cancer. Number of patients is around 54, with the good response rate is around 57. Duration response is good. The response rate in the CNS metastasis also is good, is around 15%. So definitely we can use this drug as a patient who has a CNS metastasis presentations. Next slide, please. Yeah. So the adverse effects mainly their receptor, and according there is a main adverse effect. You can see in this chart weight gain, dizziness, ataxia, withdrawal pains, and paresthesia, because they are related to their receptors. TRK inhibition mainly related to neuropathy, and anidosis, TRKB mainly for hyperphagia, and dorsal root neuron loss, and TRKC inhibition for the mainly proprioception. So you can found the side effect accordingly. Next slide, please. Yeah. So this is a mutation mechanism. You can find on target resistant common after TRK inhibitions. So solvent front mutation is the most common resistant mechanism in the NTRK fusions. So next slide, please. Yeah. Some drugs, mainly this is a ciltrectinib, repotrectinib, and taletrectinib, has some good activity in the first line mutations, those who are in TRK TKIs. Next slide, please.
So request you to conclude in 1 minute. Thank you.
Definitely. So request to my conclusion only. Next slide. Yeah. So for the ROS1, first generation ROS TKI approved for the TKI naive patient is crizotinib and entrectinib. And the front mutation is ROS1 is G2032R is the most common target accurate resistant mutation. And the NGS ROT TKI to overcome this mutation and our developing phases is retrotrectinib, taletrectinib, and NVL52. So this is the TKIs, those who are in developing phase, and the used one is crizotinib and entrectinib. And for the TRK mutations, definitely larotrectinib and entrectinib. Thank you.
Excuse me, can you share the slide, please?
Yeah, we are live.
Okay. Today we'll be discussing the real-world evidence of osimertinib as a standard of care in the management of EGFR mutated NSCLC. Next slide. As we all know that in the EGFR mutated lung cancer, there is an improvement in PFS and OS, which was seen with third generation TKI, that is osimertinib, which is an irreversible third generation EGFR TKI, which has shown us the meaningful improvement in PFS as well as OS, which was seen only in this TKI as compared to the other two generation TKIs. PFS advantage of 18.9 months versus 10.2 months, and median OS was seen of 38.6 months as compared to 31.8 months. Next slide. Next slide. This is a study design, it is a double-blind study design. In this, inclusion criteria was age more than equal to 18 years and good performance status of the patient with exon 19 deletion or L858R mutation with no prior systemic anti-cancer or EGFR TKI therapy. In this, only stable CNS meds were allowed. It is stratified according to the exon 19 deletion and L858R and according to the race of the patient. It is divided into osimertinib arm, and comparative study was taken in which gefitinib or erlotinib was taken. In this, assessment was done at every 6 weeks and then until the objective progressive disease. The secondary endpoint was the final OS and the PFS was taken as the endpoints. Next slide. The baseline characteristics were much comparable between the two arms. As we can see in this, the majority of the patients were non-smokers, and the performance status was good. In this, they have included mostly the adenocarcinoma only. 99 patients were included on the adenocarcinoma etiology only, and almost the characteristics were comparable between the two studies. Next slide, please. In this graph, we can see clearly that if the patient is on osimertinib, there's a clear difference of the graph. And we can see that 18.9 months PFS advantage was seen with the osimertinib arm as compared to the other comparator, EGFR TKI arm. We can see in the forest plot also that all the diamonds are being favoring towards the osimertinib arm, even in the Asian population or non-Asian population. It is more seen in non-smokers as compared to smokers. And this it has shown significant improvement in the PFS. Next slide. Similarly, we can see in the OS analysis. In the OS analysis, we can see that osimertinib, when compared to the other EGFR TKI, there is median OS advantage 38.6 months as compared to 31.8 months, which was statistically significant also. Next slide. We can conclude from the FLORA study that it is the only study which has shown the statistically significant improvement both in OS and in PFS improvement. And after 3 years, almost 28% of the patient in the osimertinib arm and 9% patient in the other arm were remained on the first-line study treatment. Next slide. In the NCCN guideline, as it is of 2021, now latest also 2023 also, still it holds a good first-line therapy only in the EGFR mutated lung cancer, as the osimertinib is only used as a first-line therapy in EGFR mutated NSCLC. Next slide. Next slide. Next slide. Next slide. We can now we will study about the real world evidence of osimertinib. In this, we will study the 3 studies, FLAST study and OSIFACT study, in which we will look over the real world evidence of osimertinib when compared to the FLORA study. Next slide. Next slide. In the study, they have shown that osimertinib, it is being compared to the phase 3 randomized FLORA trial, in which we have seen already shown the PFS and OS advantage. Now we have to see the real world data of this particular study. Next slide. In this, baseline characteristics were almost same. Median age was taken at 68 years. In this, the main point is in that we have not involved the unstable brain mets patient. In this, we have included all the patient which were symptomatic at presentation also. Next slide. Inclusion criteria is age more than 18 years, histologically confirmed diagnosis of NSCLC, presence of one or more EGFR mutation in exon 18 to 21. Locally advanced recurrent or metastatic disease was taken, and patients were only eligible to receive first-line treatment with third-generation osimertinib. And exclusion criteria was patient who received the other study drug in the clinical trial. Next slide. In this, the study endpoint was different as compared to the FLORA trial, in which we are seeing that median time to treatment discontinuation, and then we are seeing that rate of treatment related adverse effects. That what all are the adverse effects which were seen in the study, and how much the time to treatment discontinuation was seen. And secondary endpoint was OS survival, progression-free survival, overall response rate, and disease control rate was taken. And also we will study about the diagnostic therapeutic pathway, that why the osimertinib became resistant in this patient. Next slide. Yes, in this slide, in the study, which as compared to the FLORA study, which the main point are the rare EGFR mutation, patient with poor PS, and patient with comorbidities, and patient with active brain mets were included, which were excluded in the FLORA trial. And then outcome were similar to the published data, thus adding consistency to the osimertinib efficacy. This means even if we give osimertinib in all these subgroup of the patient, we get comparable result as compared to the FLORA trial. There was no difference in PFS or time to treatment discontinuation, and OS was noted in elderly patient with comorbidities and less common EGFR mutations. Next slide. In this graph, we can see that if the patient has no symptom, or if the patient has less than 3 metastatic sites, and the median is not reached. But if the patient has symptoms and has more than equal to 3 metastatic sites, the median was reached around at 18.8 months. So from this, we can conclude that poor outcome of the disease was taken if the patient has symptomatic brain mets, or if the patient has a bulk of disease, like more than 3 metastatic sites were present. Next slide. In the they have shown the similar thing only, discuss the similar thing. Next slide. In this, the last slide, you can last point, you can see this, that if time to treatment discontinuation appears to be a more suitable endpoint to validate the treatment outcome in our real world data, it was longer as compared to the post progression outcome analysis of the FLORA trial, because we have taken the patient who are unfit for further therapy or different therapy for oligoprogression. It means that we are continuing the same therapy even if the patient has isolated progression or oligoprogression. We are putting the patient only on second line therapy or other therapy if the patient has significant progression is there in the disease. Better treatment time to treatment discontinuation was seen if the patient has less than 3 metastatic sites and isolated progression was seen. Next slide. Next slide. In this particular slide, they have shown that there were poor treatment outcome which was seen if the patient had brain mets which was symptomatic and with more than equal to 3 metastatic sites, which is a negative prognostic factor in the study. Next slide. Next slide. Next slide, please. After a median follow-up of 12.3 months, the median PFS was 18.9 months, and OS was not reached at the time of data cutoff. So we can see that partial response was seen in 92 patients, that is 73%. Stable disease was seen in 29 patients, that is 23%. And progression was seen in only 5 patients. Next slide. The same thing they're explaining in the PFS also. If there are no brain mets, or if there are no symptoms, or if there are less than 3 metastatic sites, the PFS has been not reached. But if the brain mets were present and if the symptom were there, then median PFS was around 15 months. Next slide. So in the multivariate analysis, they have found that there was a longer PFS was noticed in the absence of brain mets, in the absence of symptoms, and time to treatment discontinuation was more than 9 months, which was significantly associated with better OS, better overall survival. So we can see that if the patient is asymptomatic and if the patient has less than 3 metastatic sites and if the patient has stable brain mets, then the PFS was longer as compared to the symptomatic patients. And because of the longer PFS and because of the longer time to treatment discontinuation, there was a better OS advantage which was seen in all these patients. Next slide. In this, they have shown that if the patient has shown the progression on osimertinib, in that we have in those cases, the rebiopsy was done at progression, and tissue rebiopsy was done in 14 cases, and liquid biopsy was taken in 6 patients. And at the molecular analysis was performed in 13 patients, that's 61.9% of the samples, in which we have seen that there was seen of MET amplification was seen in 4 patients, EGFR amplification was seen in 1 patient, and HER2 amplification was seen in 1 patient. Next slide. Next slide. They in this slide they have shown the safety data. The most common symptom side effect on osimertinib was diarrhea, rash, and paronychia. And the less common but the most severe symptom which was seen side effect which was seen in osimertinib arm was venous thromboembolism. Next slide. So we can see that 87% patient experienced adverse events, and 33 out of which 33% experienced grade 3 to 4 reaction. Venous thromboembolism was the most common and dreadful situation which was seen on patients on osimertinib arm. In the real world ASTRIS study, the grade 3 pulmonary embolism accounted for 2% of the pre-treated patients receiving osimertinib. Next slide. Although there was no difference was seen in the rate of venous thromboembolism as when we see the age, performance status, comorbidities, and tumor load. Next slide. No difference in survival outcome was observed according to the age, comorbidities, and type of EGFR mutation. Osimertinib confirmed effectiveness and safety in the real-world scenario also. As we can see, almost 87% patients who have experienced the side effects, which were more out of which more common were rash, diarrhea, and paronychia. Few patients suffered from venous thromboembolism, which has to be seen cautiously. Next slide. Now, this is the next study which we'll be discussing, that is osimertinib as first-line treatment for advanced EGFR-mutated non-small cell lung cancer in the real-world setting. Next slide. In this, we will be discussing about the difference in the efficacy with the patient background and the safety of the first-line osimertinib treatment in the real-world scenario. Next slide. Inclusion criteria, they have taken advanced EGFR-mutated NSCLC with osimertinib as the initial treatment. In the exclusion criteria, they've excluded all the patients who have taken other anti-cancer agent or undergoing thoracic RT or undergoing post-adjuvant chemotherapy or receiving osimertinib as a second-line treatment. Next slide. In this, they have taken the patient's performance status was almost performance score of 0 to 1, which were taken in the dominant majority of the patient. And then we can see that in this PD-L1 TPS score was seen in almost more than 50% in 11.9% patient. Less than 1% PD-L1 TPS score was seen in 30% of the patients. And they have also taken the symptomatic brain mets and asymptomatic brain mets and malignant pericardial effusion plus liver metastasis, which we'll be discussing what will be the effect if the patient has all these things. Next slide. In the study, endpoint was primary endpoint was PFS and secondary endpoint was overall survival, time to treatment failure, response rate, safety and post-treatment, objective response rate, and disease control rates. Next slide. We can see that PFS events occurred in 182 out of 538 patients, in which median PFS was 20.5 months, which was almost comparable to the FLORA trial. Next slide. Next slide. In this, they have shown the factors which were associated with the poor PFS. They include male gender, malignant pericardial effusions, liver metastasis, and advanced unresectable cases. With respect to PD-L1 expression, we have seen that median PFS was not reached in patients with TPS less than 1%. And median PFS was 14.7 months with TPS less than 49%, and 11.1 months for those with TPS score of 50%. And the median PFS was not reached in patients with TPS of unknown. Next slide. So we can clearly see that median PFS was not reached if the PD-L1 TPS score was less than 1%. It means if the therapy works well, if the PD-L1 score is almost the less. In this, we can see the PFS endpoint. We've already discussed if the patient, if it is a male gender, and if it is malignant pericardial effusion or liver mets are present, then we have a poor PFS as compared to the other group of patients. Next slide. In this, they have shown the reason for treatment discontinuation.
Dr. Neha requests you to conclude your presentation in 1 minute.
Okay, ma'am. And this, they have shown the reason for treatment discontinuation, which we can see that around 44% patient have disease progression, 25% patient have pneumonitis, 16% of the patient have other adverse events, and 14.2% patient did not follow up. Next slide. Next slide. Next slide, please. Yeah, I will conclude my presentation. In this, we have seen that overall response rate of 76.2% and disease control rate was 94.1%. PFS is better with osimertinib than with conventional EGFR TKI, irrespective of PD-L1 expression. Median time to treatment failure was 19.1%. 19.1 months. Median time from start of treatment to onset of adverse event was seen in from 56 days. Pneumonitis of all grades was seen in 12.8% of the patients. So PFS after first-line osimertinib in real-world practice was favorable. So we can conclude that osimertinib holds really good in the real-world setting as well, even in poor performance status patients. Thank you.
Thank you, Dr. Neha, for a nice talk on osimertinib in lung cancer. Now I invite Dr. Ankit Nehra for a talk on Raise the War in ALK positive metastatic NSCLC. Ankit, over to you, please.
Thank you so much, sir. Tarjan Boss and Pfizer Pharma for giving me this opportunity. I'll just share my slides and let me know, sir, if my slides are visible.
Yes, sir, it's visible. Make it full screen, please.
Yeah, thank you. So
Yes, it's visible now.
The first line management of ALK positive non-small cell lung cancer, how to walk in the front line setting. These are my discs, and as you know that 2007 there was a discovery of the EML4 ALK translocation, and followed by first generation TKI of crizotinib was approved in 2012. In 2015, second generation TKIs came in the picture, which in 2017 became a first line setting approval. And in 2019, lorlatinib came in the picture with the FDA approval, and FDA approval for the same for the lorlatinib in the first line setting came in 2021. So what is the unmet need of ALK positive non-small cell lung cancer? We all know that ALK positive non-small cell lung cancer patients are usually young patient, either non-smoker or light smoker. One third of those patients present with the brain metastasis, or either have a brain metastasis at the time of treatment. And what challenges we face with using a first generation or second generation TKI is that the patient usually develops an ALK resistant mutation, or the patient develops a CNS metastasis with those TKIs who do not penetrate the disease. And finally, there is an additional TKI, ALK TKI, that prevents the emergence of subclones in the untreated patient, which again is the unmet need, that what should be the best TKI to be used in the first line setting. So discussing about the first line setting TKI, what general consideration should be taken for that agent, what is the response rate of that agent, what is the progression-free survival, what is the overall survival, what is the overall efficacy, whether the second line agent is available or not, and most importantly, whether the TKI is CNS penetrable, and what is the CNS activity of the patient for the agent. So lorlatinib phase 3 crown, I will be discussing about the phase 3 crown trial of the lorlatinib. So eligibility criteria was either unresectable stage 3B or
metastatic 4L positive non-small cell cancer, which who did not receive any systemic therapy for the metastatic setting with the ECOG performance status of either 0, 0, 1 or 2. Those the patient who are either asymptomatic for the brain metastasis, brain metastasis or untreated with it, or more than one extra cranial measurable target lesion, was randomized with almost around more than 300 of the patient randomized between lorlatinib third generation TKI versus crizotinib first generation TKI, and again stratified according to the brain metastasis, whether it was present or not, or ethnicity, whether the population was Asian or not. And the primary endpoint was PFS with the independent central review, and the secondary endpoint was again PFS by the investigator, overall response rates, overall survival, safety, and quality of life, and intracranial time of progression. So, coming to the next slide, whether the independent central review of progression-free survival if you see the 36 month data, median progression-free survival was not reached with the lorlatinib arm, versus it was only 9.3 with the crizotinib arm, with the hazard ratio of almost 0.2, and patient was showing at the PFS percentage of 63% at 3 years versus only 18% with the comparator arm, which was crizotinib. And patient, if we talk about the PFS with or without brain metastasis, so hazard ratio with the patient who were presented with brain metastasis was 0.2, and again with those the patient who are not presented with the baseline brain metastasis, again the PFS was 0.29 again. And if we talk about three major first line cross trials data, so 3-year PFS rate with the lorlatinib in the crown trial was 63% versus 18%. In the ELTA trial, which was compared between brigatinib and crizotinib, again more than almost around 300 patients, were 43% versus 19%. And talking about the hazard ratio between the experimental arm versus the comparator arm, which was 0.27 in the crown trial, which was between lorla and crizo, and ELTA 1 first line trial, which was 0.48 between brega and crizo, and LX trial alectinib versus crizotinib, which was around 0.5 with the hazard ratio. So talking about the hazard ratio, either by the independent cohort review or investigator assessed data. So with the crizotinib, the hazard ratio of being positive when it was compared with the chemotherapy comparator arm, it was 0.45. Again, going with the either a serotinib or alectinib and brigatinib or encertinib, it was almost around between 0.43 to 0.45. And talking about the lorlatinib, the hazard ratio, which is quite significant, was 0.2. And being a medical oncologist, seeing a hazard ratio of 0.2 is very exciting for us with the in the setting of metastatic lung cancer patients. So projection of the lorlatinib, if we see the first year progression, it is a cross trial comparison. 1 year PFS rate between lorlatinib, alectinib, and brigatinib is 78% versus almost 68 to 69%. If we talk about the 3-year PFS rate, it is 63% with the lorlatinib versus 46 with the alectinib and 43 with the brigatinib. Coming to the time to intracranial progression, those the patient who did not progressed at the time of 3 years, it was 92% versus 37%. If I'm talking about all the intention to treat population, whether those the patient presented with the brain metastasis or not, with the hazard ratio of 0.08, which shows almost which shows that crizotinib arm versus lorlatinib arm, and the lorlatinib arm favoring with the progression-free survival of which was better than which was almost better with the comparator arm at more than 90% of the patients. Those the patient who had a baseline brain metastasis, again the hazard ratio is 0.1, and 73% patients do not progressed even after the cutoff of 3 years. Those the patient who did not had a baseline brain metastasis, again 99% of the patient has a progression free survival with the brain at the even after the 3 years of survival, and only 1 out of 112 patients without the brain metastasis exactly exhibited a intracranial progression with a very beautiful hazard ratio of 0.02 0.02 only. So, talking about the Crown trial with the lorlatinib, the PFS rates with the hazard ratio of 0.1, those the patient who had a brain metastasis, and hazard ratio of 0.29 with those the patient who did not had a brain metastasis. Going back to the global ALEX trial, alectinib also showed a very good survival comparing with the crizotinib, but the hazard ratio was almost double, which was 0.4 with the brain mets patient, and 0.5 those the patient who had not brain metastasis at the presentation. So rationale of using best possible agent in the first line setting, if we see the most common mutations, which are the resistant mutation, which is EML for ALK, either 1196M or G12 1202 deletion or G1269A mutation. All of the patients do had a very good response and do had a inhibitory 50% inhibitory level with the with a very significant number in the lorlatinib arm. So resistant pattern with the patient who are receiving ALK TKI. So those the patient who are crizotinib resistant specimen, we can see 1196M, G1269A or C115CY are the most common inhibitory resistant mutations. In post-serotinib or serotinib resistant specimen, it is G1210R or it's 1202 deletion. And those the patient who are resistant on alectinib, usual specimens are with the S1206Y or E1210K. So, how does the sequencing of ALK TKIs starting from the first generation TKI to the third generation TKI? So, if the crizotinib is being exposed in the first line setting, there is no mutation usually when there is a progression, and after the alectinib, at the progression of the time, there is a usually there is a G1202R mutation, and after lorlatinib, after the at the time of progression, there is a one more mutation, which is 1196M, which is usually found out. So basically, the clonal evolution of between more and more mutation can be found with the sequencing. And in the right slide also, after the crizotinib and alectinib, there is 117 1N, and after the lorlatinib, one more mutation came in the picture, which was L1198F. So those the patient who are upfront exposed with the lorlatinib, they had they can have a bypass mechanism, or they can have a transformation between other between adenocarcinoma to small cell carcinoma, or a bypass mechanism. But in the crizotinib, if we can see there can be new ALK mutations or compound mutations, which is between 8% to 12%, which is not seen in the lorlatinib arm. So sequencing two TKIs, if we are using lorlatinib in the first arm and the second TKI or a chemotherapy in the second arm, the median progression-free survival of PFS of 1+2 can be as high as 36 or more than 36 months. And if we are sequencing with the alectinib, followed by lorlatinib. The PFS1, PFS2 is 31 months, and subsequently, if alectinib is sequenced with the brigatinib or brigatinib with the second line, with the third line, or seritinib with the lorlatinib, with the lorlatinib, the PFS1, PFS2 is less than 30 months. So, talking about the major side effects of the lorlatinib, dyslipidemia or fluid accumulation, which is either being presented as a accumulation or ascites, or weight, being a weight increased with the peripheral neuropathy or cognitive decline, are the most troublesome adverse event, which is almost around 20%. If we talk about any grade, and hyperlipidemia or dyslipidemia, almost 20% of the patient did had a episode of dyslipidemia or hyperlipidemia, but the patient who had a treatment discontinuation due to the grade 3 or grade 4 adverse event was less than 1%. So cardiovascular adverse event was again quite comparable between the lorlatinib and crizotinib, which was respectively 23% versus 27%. Hyperlipidemia was again quite comparable, or slightly higher in the crizotinib, which was 24% versus 44%. So incidence of cardiovascular adverse event, if you talk about the grade 3 or grade 4 toxicities, was not actually higher in the lorlatinib arm comparing to crizotinib arm. So, talking about the long-term intracranial sensitivity and efficacy of Crown study, we have already discussed this slide in previous setting. So, so the patient, what can be the most troublesome side effect apart from dyslipidemia? There is a cognitive decline, mood swings, psychotic effects, which are there with the lorlatinib, and these side effects declines after 1.5 year of the therapy. And there are usually there are no grade 3 or grade 4 side CNS adverse events, and most of them was predominantly a grade 1 adverse events. And those adverse events was again reduced with the time, and those the patient who had usually initially a CNS metastasis was quite higher than the patient those do not had a CNS brain metastasis at front. So, in comparing, going with the intracranial safety data, majority of the patient was managed without any interventions. Only two patient, which was less than 2% of the patient, had a permanent discontinuation due to the adverse event for the lorlatinib. And long-term analysis confirmed that CNS adverse events remains manageable over the time, which was not very significantly higher with the comparator arm, which was crizotinib. And coming back to the NCCN guideline, either lorlatinib or alectinib or brigatinib is the first category 1 indication in patients who are having a brain, who are presenting with the ALK positive metastatic lung cancer. So thank you, and I want to conclude that sequencing could be the most effective option in the ALK positive lung cancer, which can either be upfront using a lorlatinib or sequencing alectinib followed by lorlatinib, which I personally feel in my clinical settings. Thank you. With that, I stop sharing my slides. Thank you, sir.
Thank you, Ankit, for a nice talk. And I also thanks Dr. Somani sir for continued blessing during today's session. And at the last, I would like to extend my heartfelt thanks to our distinguished faculties for their enlightening contribution, our engaged attendees for making this conference vibrant, diligent organizer Horizon for their meticulous planning, and additional gratitude to all our pharma sponsors, AstraZeneca, Dr. Reddy, Merck, Mankind, Freshness Kavi, Pfizer, Zydus, Magnum, and Torrent, who played a key role in the success of this oncology conference of 3 days. Your collective efforts have truly enrich this educational experience. Thanks to all.
Thank you, sir. Thank you, everyone. Thanks to all faculty for wonderful discussions and talk. Thanks for joining, and thank you for taking forward this 3-day program, a great academic feast. Thank you.